Ajmo veste, glede uradno. Jaz vas vse lepo pozdravljam. Mi bomo zdaj uradno začeli. Je večinoma 120 prijavljenih, večinoma so vsi na online. Zelo lepo pozdravljam vsi, ki ste tudi prišli in naš strokovni direktor je pripravljen, da začne z uvodnimi besedami.
Well, dear colleagues, dear friends and honored guests, I have the opportunity and privilege to welcome you to this symposium on the topic of modern management of pulmonary hypertension. I'm especially happy to welcome guests from neighboring and nearby countries, namely Italy, Austria, Croatia and Serbia. As an abdominal surgeon, the field of pathology that you are treating today is neither anatomical nor pathophysiologically close to my field of professional interest. However, I'm convinced that it is a clinically relevant and important topic, and it is obviously, it lies in the border area between pulmonology and cardiology. I also believe that the discussed topics will be illuminated in accordance with the latest professional state of art. On this occasion, and on behalf of the University Medical Center Ljubljana, I would like to thank and congratulate our colleagues from the Clinical Department of Pulmonology that despite the difficult conditions in which they work due to the problems related to the renovation of the main building of our hospital, they maintain the energy and will to develop their profession at the highest possible standard. In this connection, I would also like to highlight the good interdisciplinary cooperation they have established, especially with our colleagues from the surgical clinic, that has enabled them to bring pulmonary transplantation to our hospital a few years ago, and has enabled them also to introduce pulmonary thrombectomy in our hospital just recently. I'm convinced that today's event will be another success story in the field of pulmonology development in Slovenia, and I'm optimistic about the future of this institution despite all the challenges that we face on a daily basis. So I wish you all a successful symposium, and for our guests from abroad, a pleasant experience with professionals from this country. Thank you.
Thank you, Professor Norčič. So with this, I would like to open this meeting with our first talk from esteemed Professor Galie from Bologna, who I think does not need additional introducing because he's been in this field for decades and has been a part of pulmonary arterial hypertension story. So the talk is called Where We Came From and Where We're Going in Modern Diagnostics of Pulmonary Arterial Hypertension. Please, Professor Galie.
Thank you. Do you hear me?
Yes.
Do you see my slide? Do you see my slide and hear my voice?
We hear you. Go ahead.
Okay. Thank you for the invitation to your meeting and talking about diagnosis I believe that diagnosis is the most important part today of the strategies for pulmonary hypertension. Diagnosis is wrong also the therapy. And in my talk, I will analyze first the initial diagnosis of pulmonary hypertension, and then also the differential diagnosis between the 5 groups of pulmonary hypertension. The diagnostic process has 2 aims: early suspicion of pulmonary hypertension and fast-track referral to pulmonary hypertension center in patients with a high likelihood of PAH, CTEPH, or other forms of severe pulmonary hypertension. The second aim is to identify underlying disease, especially left heart disease group 2 and lung disease group 3, as well as comorbidities, to ensure proper classification, risk assessment, and treatment. These are the symptoms of patients with pulmonary hypertension, early symptoms and also late symptoms. They are both aspecific, and this is relevant for the subsequent workup. Symptoms are dyspnea, fatigue, and palpitation, hemoptysis, exercise-induced abdominal distension, weight gain, and syncope. And then there are also late symptoms related to the dilatation of the pulmonary arteries and compression of other organs, like the dynamic compression of left main coronary artery, which may produce angina, dysphonia, and then also shortness of breath, wheezing, and cough if there are compression of other of bronchi. And these are the signs, and the signs are related either to pulmonary hypertension or to the condition of the right ventricle. So signs of pulmonary hypertension is, for example, mixed cyanosis and other characteristic like the right ventricular third heart sound. But also those characteristics are aspecific. And also there are some signs who point toward the cause of pulmonary hypertension, like digital clubbing and cyanosis, which are typical of congenital heart disease, but also to bronchiectasis and pulmonary PVOD. And the signs of failure may be backward, like hepatomegaly, ascites, and peripheral edema, or forward. And typical of forward failure may be dizziness, syncope, pallor, and cool extremities. And then also the initial profile is different according to the 4 most relevant groups, from 1 to 4. For example, group 1 PAH, the patients are variable age, but the young female patients may be predominant. Patients associated with left heart disease also has some characteristics related, for example, to the age or to specific type of heart failure, like heart failure due to preserved ejection fraction, and then pH related to lung disease and chronic thromboembolic pulmonary hypertension group 4. This is a group of patients in our registry. You see that the age of the patients is older if we consider and compare group 1 and group 2, and also other differences are present in other groups. And then the ECG. ECG is very frequently altered in pulmonary hypertension, and but there are differences according to the different groups. This is a typical ECG of patients of group 1, pulmonary arterial hypertension, with the typical right atrial strain, and then also the typical changes that we define right ventricular hypertrophy. And then echocardiography. Echocardiography is very relevant, and it plays an important role because we may identify by transthoracic echo the enlargement of the right heart chambers, the flattening of the interventricular septum, the dilatation of the inferior vena cava, the RVOT acceleration time, and the reduced right ventricular fractional area change, and so on. And also it's important to take into consideration specific changes like the dilatation of the ventricle and the pulmonary artery, also dilatation and acceleration time, and inferior vena cava and right atrium dilatation. And then for echocardiography, we know that we are not able to measure precisely pulmonary arterial pressure, but to give an estimation. This is why in the guidelines we provide velocity, peak velocity of tricuspid regurgitation, and we transform this figure in probability. Pulmonary probability, pulmonary hypertension probability may be low, may be intermediate, and may be high. For example, if the velocity is inferior or equal to 2.8 meter per second, and there are no additional signs of pulmonary hypertension, the probability of pulmonary hypertension is low. If the velocity is between 2.9 and 3.4, and there are no additional signs of pulmonary hypertension, the probability is intermediate. And if the velocity is more than 3.4, and again there are no additional signs, the pulmonary hypertension probability is high. As a consequence, if the probability is high and there are or not signs typical for PAH and CTEF, further right heart catheterization at this point is required. Otherwise, if there are no additional signs, echo follow-up is maybe required, and in low probability group, if there are no other signs, an alternative diagnosis may be required. So, as you can see, there is an important role for this table, in which we have the probability from one side and the further type of follow-up after. And then also there are some specific tables which may help in the differential diagnosis, in this case, between group 1 PAH and group 2 left heart disease, according to different features like age, coronary artery disease, risk factor, diabetes, the presence of non-left heart disease, previous cardiac intervention, atrial fibrillation, structural left heart disease, and so on. We can define the given patients like unlikely pulmonary arterial hypertension due to left heart disease, or intermediate probability of pulmonary hypertension due to left heart disease, or likely pulmonary hypertension due to left heart disease. For example, this is characterized by age more than 70 years, 2 coronary risk factor, the presence of left heart disease, the presence of left branch block, and so on. And also the chest X-ray, the first chest X-ray may help in the differential diagnosis, because we can identify signs of pulmonary hypertension and concomitant abnormalities. In this case, this is a PAH patient with important dilatation of the central pulmonary arteries. And this is patients with pulmonary hypertension with signs of left heart disease. This is a pacemaker and congestion of the lung fields. And this is a chest X-ray of a patient with pulmonary hypertension and likely emphysema. And so we can assume that this patient, if there is pulmonary hypertension, is group 3. And finally, between group 1 and group 3, the differential diagnosis can be performed utilizing the extent of lung disease, like the severity of pulmonary function testing changes, and also analyzing the high-resolution CT scan, analyzing the hemodynamic profile with mild to moderate pH in patients with group 2, and more often moderate to severe pH in group 1. And then in the diagnostic process, we have additional, we can say, second place, the VQ scan, the CT scan, and MRI. For VQ scan is very important, because if it's normal, this excludes chronic thromboembolic pulmonary hypertension. CT scan is also important for both identifying the diagnosis of CTEF, or also identifying signs of parenchymal lung disease, like in PVOD and PCH. For MRI is important because this specific investigation is the gold standard for the assessment of right atrial and ventricular sides morphology and function. And this is the CTEF diagnostic algorithm. In this diagnostic algorithm, the patients is included because maybe he was on a pH workup, or the CTEF is suspected from history of pulmonary embolism. And then additional examination are VQ scan and echocardiography for the probability of pulmonary hypertension. And if both are positive, the patient has to be referred to CTEF or pH center, where a comprehensive workup will be performed, like CT, pulmonary angiography, or the digital subtraction angiography together with the right heart catheterization. And then the patients will be discussed in expert groups who are able to perform, for example, endoarterectomy or balloon pulmonary angioplasty, or use the approved drugs. And this has to be done as soon as the diagnosis of CTEF is confirmed. Then there are also lab tests which may identify comorbidities or complications, or also causes of pulmonary hypertension. Abdominal ultrasound is useful for confirming the presence of portal hypertension or portocaval shunts, like in patients with Abernethy malformation. And also is important in some patients to provide the data with the CPET, which may show typical changes according to the different types of pulmonary hypertension. And the comprehensive diagnostic algorithm starts with the suspicion. And after the suspicion, there is the confirmation, and it's important to send very fast patients which warning signs of severity. And then in this expert center, the diagnostic process will be completed fast. Which are the warning signs suggest fast track? Are symptoms and severe symptoms, severe reduced exercise capacity, signs of low cardiac output, state of compromise or deteriorated hemodynamic status with hypotension, tachycardia, presyncope, on mild exertion, and the signs of right heart failure, poorly tolerated arrhythmias. Then, and this is the fast track toward the referral center. If severity is not predicted, then the first part of the diagnostic algorithm is to identify lung disease or heart disease, and in this case, rapid cross-referral may be needed. Then we can utilize also the probability, the pulmonary hypertension probability. In fact, in the case of intermediate to high probability, also in this case, the referral to an expert center is recommended. If the probability is low and other causes other than pulmonary hypertension are identified, further the diagnostic workup is recommended. And then the screening. Screening may be important in some categories of patients with pulmonary hypertension because the delay between symptoms and diagnosis remains very up to 2 years of delay. And screening may be performed in asymptomatic patients with high-risk group, like scleroderma spectrum of disease, BMPR2 mutation carriers, and patients undergoing to liver transplantation. But also in symptomatic patients is important, symptomatic patients in at-risk group are important to be investigated, like in patients with portal hypertension or HIV infection or non-scleroderma connective tissue disease. And also early detection of patients post-acute pulmonary embolism is relevant for the early identification of chronic thromboembolic pulmonary hypertension. In fact, after the diagnosis of acute PE and anticoagulation treatment for 3 to 6 months, if the patient has dyspnea after 3 to 6 months at the follow-up visit, it's important to perform the transthoracic echocardiography, and in case of high probability of pulmonary hypertension, VQ scanners to be performed, and referral to expert center also is required. If there are no symptoms, so the patient is evaluated according to the presence or not of findings which may suggest the evolution toward chronic thromboembolic pulmonary hypertension, ventricular atrial shunts, for example, infected chronic intravenous lines or pacemaker, history of splenectomy, and so on. Also, these patients need to be assessed for the presence, even if they are non-symptomatic, they have to be investigated for the presence of chronic thromboembolic pulmonary hypertension. So, in conclusion, we start with the suspicion of pulmonary hypertension, and we take into consideration the fast-track referral if an high probability of pulmonary hypertension or chronic thromboembolic pulmonary hypertension or severe pulmonary hypertension in group 3 are detected. It's important to identify underlying disease, especially left heart disease and lung disease. If intermediate high pulmonary hypertension probability is excluded, in any case, we need to exclude also Dept without pulmonary hypertension. Referral for right heart catheterization, PH expert center, is very important, and also for the diagnosis of CTEF or Dept. Thank you.
Thank you very much. We have now an opportunity to ask some questions for Professor Galie. Do we have any questions from the online audience? Yes? Kako pa je vidim jaz česa? Barbara, would you like to? Yeah. Put some. Yeah.
Professor Galie, thank you for your presentation which show us the view of how we have to approach to manage to diagnose patients with suspicion for pulmonary hypertension. And this story about a development of these procedures is long, and I would like to thank you here at the beginning of the discussion for all your help you provide to us in Slovenia. And I saw you put a rainbow after in your picture, and this was really one sign to me. When I came from Bologna, the rainbow was at the border. When I learned how to approach to patients with pulmonary hypertension in your institution, when I crossed the border, and you didn't know that, there was a really huge rainbow, never before. After, once again, when I came back from Ireland for cystic fibrosis, really 2 times on the border. And you really help us, and after 20 years, since 2003, we really made a good improvement, and today is the time when I put to younger colleagues all the responsibility for this. I step backward, and at this occasion, I really would like to thank you for all this, what you provide to us in Slovenia. Without, you always do this for free. All lectures or expert opinions when we battle for really the most difficult patients, and thank you very much for this.
Thank you very much. And in fact, this is the rainbow beside the tower. As you know, we have a problem because we are losing one tower in Bologna, but we are fighting to preserve it. And actually, I see the tower, the rainbow from the window of my apartment. I like it very much.
Okay, so can I ask you a question? I would
yes.
Be glad if you could comment on whether advances in heart echo and MRI will be, if you think that they will replace some more conservative methods of diagnosis. For example, right heart catheterization is a rather difficult procedure that has to be performed on every patient with pulmonary arterial hypertension. Can we replace that with non-invasive methods?
Not completely. At least first right heart catheterization at the time of diagnosis has to be performed, even because in different types of pulmonary hypertension we need a vasoreactivity test. And because there is still some diagnostic differentiation between group 1 and group 2 left heart disease, in which is required the measurement of the wedge pressure to be sure that this is group 2 and not group 1. Then other centers utilize right heart cath also during follow-up, like our center, but it's not required. I agree with you that utilizing echo and MRI, we can have parameters and information which are similar to the right heart catheterization. But believe it, perform also logistically a right heart cath rather than an MRI. Even if we have 3 MRI machines, MRI now is absolutely utilized in all fields of medicine, and it's very difficult to get this examination timely for our patient, even if, of course, we utilize it. With pulmonary hypertension.
Okay. Okay, thank you for your answer. Just to inform everybody, there is a link on Slido where you can ask your question. Any further comments or questions for Professor Galie? Yeah? Question from Dr. Toplišek.
Hello, do you hear me?
Yeah.
Okay, so I'm doing echoes, and in the new guidelines there was a ratio TAPSE through SPAP introduced, and I wonder whether this ratio is, in your opinion, more prognostic or more, let's say, diagnostic tool. What do you think?
I'm not an echocardiographer, so it's, and we do not utilize this parameter, even because if it's correlated with survival, a comparison between this parameter and other parameters like 6-minute walking distance or NT-proBNP has been compared with this parameter, because this is very important. We have multiple parameters who are correlated with the prognosis of PAH, including echo, MRI, including right heart cath, including exercise capacity. But we need a small, if possible, a small group of these parameters, not all, because all is confusing. And to do multivariate analysis with multiple parameters, we require very large studies who have not been performed. All the prognostic studies are performed with not more than 100 patients. So unless we perform a multivariate analysis, we will identify if a parameter is better as compared to what we are assessing now. But physiologically, the parameter you cited is logical, but a definite proof that this is better to the others has not been achieved.
Thank you.
Okay, thank you very much for this interesting discussion. So we move on with our program. We will have a discussion for the next topics will be joined for all the presenters. And I would like to invite my colleague, Dr. Mlakar, with the talk, Proper Diagnostics in Specialized Centers.
So hello to everybody. I'm going to talk about the proper diagnostics of pulmonary arterial hypertension, especially in University Medical Center in Ljubljana at our department for pulmonology. So our aim, as Professor Galie already said, is that the diagnosis is set straight, and we are in good collaboration with the PAH Association of the Patients, and we're trying to push as many doctors as possible to think about this rare disease, so to raise early suspicion about pulmonary hypertension. And the subgroups, the subclasses of pulmonary hypertension, which are rare and the ones that deserve specific pulmonary hypertension therapy, should get a fast-track referral to the PH center, which now is in University Medical Center in Ljubljana. And also, when we do this diagnosis, we have to think about the underlying diseases that might cause pulmonary hypertension. And today we're talking about pulmonary arterial hypertension, and the guidelines have new algorithms for diagnostics of pulmonary hypertension, and this is actually in Slovene language, but 6 years ago, me and Barbara did an algorithm for general practitioners, which is really similar to the algorithm which is in the guidelines from the last year. And it says that if a patient has out of proportion dyspnea, the GP has to think about if it's an acute thing, an urgent thing, to send him to, of course, to emergency department to rule out pulmonary embolism, for instance, and to rule out the most common causes of pulmonary hypertension, which are, of course, left-sided disease. So to think about to sending him to cardiologists and also to pulmonologists, which is the second most common underlying disease for which is causing pulmonary hypertension. And then, of course, the most important thing that we do is ultrasound of the heart. And then if there is a high or at least moderate probability of pulmonary hypertension, of the rare causes, or if somebody has certain diseases that might be linked to pulmonary hypertension, then he has to send this patient to our outpatient clinic for pulmonary hypertension. So this is an algorithm from these guidelines from 2022, which says that general practitioner has to do some investigations, which are simple: ECG, physical exam, of course, medical history. Professor Galie already talked about the symptoms. And then also to think about the two most important diseases, so lung diseases and cardiac diseases, that are the most common causes of pulmonary hypertension. And if these diseases are treated well and the patient still has symptoms and the echo says that there are probable signs of pulmonary hypertension, then he has to go further to an expert center. Of course, there are always some warning signs when the general practitioner or another doctor has to think about these signs, which are rapid progression of symptoms, signs of right heart failure, presyncope or syncope upon exertion. He has to fast track these patients without thinking about this to our center. So we find this, we do the diagnostics as fast as possible. So how do we do it in University Medical Center in Slovenia, in Ljubljana? So we have a good collaboration with the Patients Association, and we actually in the past 10 to 15 years raised an awareness about this disease, about the rare causes of this disease. So class 1 and class 4, these are the patients that get specific treatment for pulmonary hypertension, and we actually get 3 to 5 referrals per week to our outpatient clinic. And most of the doctors who are sending these patients are general practitioners, cardiologists, pulmonologists, and rheumatologists, also, of course, other specialities. And when the patient comes, when he comes to our outpatient clinic, the first thing we do, we take a thorough medical history. We look at all the documentation. Usually, these patients come in with documentation, with performed echo. We actually have a small, short questionnaire which they form out while they're waiting for our exam, and then we save time when he comes in. So there's the questions about his dyspnea, or his functional status, other diseases, and a therapy he's taking. We all do at the same first visit. We do X-ray, we do ECG, lab results, including rheumatology testing for antiphospholipid syndrome, thyroid function, and the basic results. I mean, kidney function and all the markers for right heart failure. And we also do at the first time, if it's possible, of course, we do a 6-minute walking test. Then we get back all these results, usually the same day or in the following day. and I am a pretty doubtful person, so I always check. I don't do echo, but I think I know a little bit about echo, and I check all the parameters, and I doubt a lot about these echos, especially if they're not performed in big centers in Slovenia. So I'm thinking about should we repeat an echo or not? I know the fellow cardiologists will be really angry, but there are a lot of times an echo comes, which is perfectly normal, but really high velocity of tricuspid regurgitation, and I just cannot put the puzzles together to say that this is pulmonary hypertension and looking at the patients who is actually normal, fine, without any whatsoever problems. So we think about repeating echo. Of course, we exclude chronic thromboembolisms for every patient that comes into our outpatient clinic. Usually they also get CT of the chest. And if looking at the prognosis of the patients with pulmonary hypertension and with PEH, some of the groups have worse prognosis, and the ones that are probably in this group have a fast-track referral to right heart cath. My colleague David is going to talk about this, and I must say that the patients who are in the groups with really poor prognosis, so the patients with PVOD, with portal pulmonary, and the ones with the connective tissue diseases can actually get a right heart cath in a week 2, maybe most 3 maximum. And there are also many other investigations, and I won't go to detail. So our goal of diagnosing really rare causes of pulmonary hypertension, which is PEH and chronic thromboembolic pulmonary hypertension, is to set the reliable diagnosis, not to be in doubt that this is a pre-capillary pulmonary hypertension, to fast-track the patients who have the most poor prognosis to get the invasive diagnostics fast, because it's really important to start the treatment early to improve the prognosis of these patients. So I think I can say that we are a specialized center now. We have quite a lot of experience. Barbara started this, I can say, decades ago, and we have a good multidisciplinary team, and I'm really grateful that I'm a part of this team. And these are my contacts in case anybody has any questions. We are really responsive. Thank you.
Okay, thank you, Polona, for this interesting talk. Do we have any questions for Polona? Oh, sorry, I'm sorry. We will have questions at the end of this. So I would like to invite now Dr. Listan to present us the role of right heart catheterization in a specialized center for PH.
Okay, hello. My name is David Listan from the department as my former colleagues. And I'll talk about our experiences with the right heart catheterization. So the right heart catheterization is actually minimally invasive procedure which allows us to directly make the measurements, hemodynamic measurements of the right heart and the pulmonary pressures. It is still the gold standard technique, although the ultrasound is very good to estimate, especially in our center, about the pulmonary hypertension, but still the gold standard technique is the right heart catheterization. With this technique, with this procedure, we can differentiate between precapillary, postcapillary hypertension and volume-driven elevated pulmonary artery pressure. And beside that, it's also a very good tool to establish prognosis and to assess the response to treatment. So the definition of the pulmonary hypertension, as you heard before, is that it is the mean pulmonary artery pressure, the same or above 25 millimeters of mercury at rest, measured with right heart catheterization. With this, we can differentiate between precapillary, isolated postcapillary, combined pulmonary hypertension, measuring the of course, mean PAP is always elevated, and with the wedge pressures and pulmonary vascular resistance, with the values which can differentiate these conditions. So the procedure of the right heart catheterization starts with the patient preparation. Of course, the most important thing is the history, where you can assess the risk. Let's say any inability to lay flat, any latex, let's say allergies and stuff like that, and also contraindications with masses or any thrombi in the right heart, after any cardiac operations and stuff. After that, we have to check the anticoagulation therapy. We have to stop it. We check with the warfarin, we check the ENR, which should be below 1.5. We stop the NOAC and clopidogrel 2 or 5 days respectively before the procedure. Before the procedure, we again check the ENR, hemoglobin, thrombocyte count, renal function, electrolytes, and also ECG, and all the patient has to have the written consent for the procedure. So we do it first in the under the ultrasound. We check find the right internal jugular vein, and we give the xylocaine to the skin and near the vessel, so to prevent any pain. Then we prepare the guiding wire, the sheath, and with the dilator. And again, under the ultrasound, it's actually ultrasound guided. We puncture the internal jugular vein, introduce through the needle, introduce the guiding wire, and slide over the dilator with the sheath. And this is the sheath in place in the right internal jugular vein. Then we prepare the Swan-Ganz catheter. This is the catheter we use for the measurement, which is bilumen catheter with the balloon on the top, on the tip, and also a thermosensor at the tip. Then we measure the reference 0 point, which is in the level of the, actually it should be in the level of the right atrium, and it is actually the point where the acromioclavicular joint is actually at the patient. We then set the reference 0, then we introduce the catheter, and then we start the measurements. We use double checking method. One is with the curves to see where we are, and the other is also the diascopy. You can see there you can see that this is in the level of the right atrium, the curve of the right atrium, right ventricle, and also the pulmonary artery and wedge pressure. After that, we measure the cardiac output via thermodilution method and also via indirect Ficht method. We take the blood samples from the pulmonary artery and the peripheral arterial blood. We also do some stress tests. This is the cycloergometer and also fluid challenge test. We also do a nitric oxide test. I don't have the picture, where we can see that there is any vascular activity. So to set the prognosis and to any treatment decisions. All the parameters we write down in this table, and then we calculate all the necessary. So in with our results, we started in 2018. Before that, we do it with the collaboration with the ICU and especially Dr. Gorjup, which introduced us to this technique and taught us everything actually we know. So we started in 2018 with as little as 17 procedures. After that, we started seriously with 49, and then the Corona came, which limited us a little bit. But after that, up to today, to this year, until yesterday, we have 76 procedures. All the procedure we did altogether, we did 249 procedures. Little more than 40% were male and little less than 60% were female, with an average year of 60.5 years, the youngest 18 years and the oldest 86 years. By the diagnosis, we have here group 1, which is pulmonary arterial hypertension, around 1/4 of the patients. Group 4, which is chronic thromboembolic pulmonary hypertension, little more than 1/3 of the patients, and about 11% didn't actually have the pulmonary hypertension. We use the diastrophy. We don't use the diastrophy all the times. Especially, we use it in the group 4 where there is a problem with the wedge pressure, with the wedging of the catheter, and with the group 1 with very big right atrium. So it was done in 39% of the cases. The complication rate was, according to the literature, quite high, but we registered all the complications, including vasovagal reactions, very slight hematoma on the punction sites, but these are very mild complications. We didn't have any major, actually, complications, as I remember. So these are our results. Again, our contacts if everybody needs it for the referral. Any questions? So.
So now I would like to invite Assistant Professor Matevž. She's our fellow cardiologist. I mean, she's a specialist in cardiology, and we're also doing a study together. We're really happy to have you and to be able to ask you the things that we don't know from the cardiology point of view. Thanks.
Hello, thanks organizer for this kind invitation. So I am a cardiologist working in an echo lab, and in my presentation today, I will discuss with you how we can use echo for assessing pulmonary pressure, and at the end, we'll briefly touch if we can use echo for distinguish pre- and post-capillary pulmonary hypertension. As already said by previous colleague, mean pulmonary pressure measured by right heart catheterization more than 20 millimeters mercury is used as a cutoff for diagnosing pulmonary hypertension. With echocardiography, we usually measure systolic pulmonary pressure, and this conventional echocardiographic alone is insufficient to confirm a diagnosis of pulmonary hypertension, as the correlation of echocardiographic measure as systolic pulmonary pressure compared to systolic pulmonary pressure measured by right heart catheterization is only modest. As you can see here, the correlation coefficient is around 0.70. Additionally, echocardiographic Doppler measurement can over or underestimate systolic pulmonary pressure by about more than 10 millimeter mercury in almost half of our patients. And what are the reasons for these discrepancies between echocardiographic measurement and right heart catheterization? As you can see here, one of very common mistake is using too much gain, and with using too much gain, we can very easily overestimate systolic pulmonary pressure, presented here on the right side of the slide. Otherwise, if the signal of tricuspid regurgitation is very weak, we can very easily underestimate systolic pulmonary pressure. However, by using a special contrast, we can enhance the signal of tricuspid regurgitation and improve the accuracy of systolic pulmonary pressure measurement. As you can see here, this is one of the first studies showing that using a mixture of 10% of the air, 10% of the blood, and 80% of the saline mixture, we can enhance the signal of the tricuspid regurgitation, which is used for assessing systolic pulmonary pressure in echo. And the correlation between echocardiographic measurement and invasive measurement was almost perfect on the right part of the slide. In our center, we used agitated colloid contrast. It's a little bit easier to prepare because we don't use blood. We just use 10% of the air and 90% of the colloid contrast, and we get quite similar quality of the signal. Already mentioned by previous speaker, right heart catheterization is a gold method for distinguish precapillary and postcapillary pulmonary hypertension, and they are using wedge pressure and pulmonary vascular resistance to distinguish between both etiology. However, also with the echo, we can assess a surrogate of wedge pressure and a surrogate of pulmonary vascular resistance. And here are the formulas we used in clinical practice. For the wedge pressure, we use the ratio of E to E prime, while for assessing pulmonary vascular resistance, we use a measurement of maximal velocity of tricuspid regurgitation and velocity time integral in the right ventricular outflow tract. And what are the correlation between echocardiographic and invasive measurement of pulmonary wedge pressure and pulmonary vascular resistance? If we at first look to the left side of the slide, where is the correlation between echocardiographic assessment of E to E prime, as I said, is a surrogate for wedge pressure, and invasive measured wedge pressure, the correlation coefficient is not very good. It's in moderate range with the correlation coefficient 0.75. Similarly, also pulmonary vascular resistance measured by echo is not optimal. However, it can very reliably assess normal and abnormal pulmonary vascular resistance, but if you can see here, all pulmonary vascular resistance measure more than 5 Woods unit during the right heart catheterization are normally underestimated by using this echocardiographic calculation. So if we can conclude at that step, we can say that there is no good conventional echocardiographic method that can reliably discriminate between pre- and post-capillary pulmonary hypertension. So recently, some authors proposed to use some provocation tests in order to improve the accuracy of echocardiographic measurement for distinguish between pre- and post-capillary pulmonary hypertension, mainly based on echocardiographic evaluation of the wedge pressure. And this is one of the recent study which compared the gold standard method, so right heart catheterization, with echocardiographic measurement during rest and during the exercise. And here is nicely visible that rest E to E prime measured by echo do not discriminate between normal and elevated wedge pressure, while on the other hand, E to E prime lower than 12.5 during the low level of exercise, so meaning 20 watts, can predict normal wedge pressure during the exercise. And this works reasonably well. The specificity was 83%. Importantly, this study only included patients with heart failure with preserved ejection fraction and healthy control. And we are at that moment, we don't have the data combining different etiology of pulmonary hypertension, so pre- and post-capillary pulmonary hypertension, and using this, I would say, small provocation test during echo to reliably assess the etiology. And due to the lack of data, we decided to start a study with our colleague from pulmonology department in order to assess the value of echocardiographic stress testing in diagnosing pre- and post-capillary pulmonary hypertension. And our colleague from pulmonology department are our gold standard, and we are performing echo with 3 different provocation tests. One is passive leg rise, which is indeed a change of a preload of 500 milliliters. And then we use hand grip, which is isometric contraction, and semi-supine bicycle. The study is still ongoing, and I would like to share with you 2 representative patients from our cohort. These are patients with precapillary and postcapillary pulmonary hypertension confirmed on right heart catheterization, and resting echocardiographic parameters were not sufficient to reliably distinguish the etiology of pulmonary hypertension during the rest. And as you can see on the slide, there are completely different pattern of dynamic of E to E prime during the exercise in both type of pulmonary hypertension. In patients with precapillary pulmonary hypertension on the left side of the graph, you can see that E to E prime, which is measured on the mitral annulus, significantly increased during the exercise. And this resulted in E to E prime, which is similar during the rest and during the exercise, suggesting that there is no increase of the wedge pressure during the exercise, which is in line with the precapillary pulmonary hypertension. In the other case, in patients with postcapillary pulmonary hypertension, you can see that E to E prime measured on the mitral annulus did not significantly increase during the exercise, meaning that there is some problem with the relaxation or diastolic dysfunction in this particular patient, and E to E prime significantly increased during exercise to the value of 19 in this patient, suggesting elevated wedge pressure, which is in line with the postcapillary etiology in this particular patient. So just a few words about the exercise pulmonary hypertension. This was again introduced in the latest guidelines. And we know that a proportion of patients have normal resting pulmonary pressure, but during the exercise, a disproportionate increase of pulmonary pressure compared to the increase of the cardiac output are noted. And this is defined indeed with the slope of the mPAP to cardiac output ratio, as presented here on the right panel. And if this slope during the exercise is more than 3 millimeter mercury per liter per minute, then this is a definition of the exercise pulmonary hypertension according to the latest guidelines. All the measurement should be performed with the right heart catheterization. Unfortunately, this relationship could not distinguish if the reason for exercise pulmonary hypertension is due to pre- or post-capillary etiology. We also know that this exercise, right heart catheterization, is very challenging, is not available in our lab over the world, and it's time consuming. Therefore, stress echocardiography could be a very nice alternative to finding the patient with exercise pulmonary hypertension, because during different level of exercise, we can very easily assess cardiac output and pulmonary pressure in patient who undergoing exercise. And as presented here, the relationship between pulmonary pressure and cardiac output can also be used during the stress echocardiography. And if the slope of the relationship between mean pulmonary artery pressure to cardiac output is more than 3, or if we use systolic pulmonary pressure, in this ratio, which should be more than 5, this is suggesting for exercise pulmonary hypertension. Okay, and for conclusion, echocardiography is widely used for assessing right ventricular function and monitoring response to the therapy. We can also use it for assessing pulmonary pressure, and by using contrast, we can improve the accuracy of measurement of systolic pulmonary pressure. There may be a rule of using echocardiographic stress testing to distinguish patients with pre- and post-capillary pulmonary hypertension, as well as also patients with exercise pulmonary hypertension. But further studies are needed to confirm if it is also clinically applicable. Thank you.
Thank you, Marta, for this lovely lecture. I'm inviting now Assistant Professor Aluzia Hocevar. She's our colleague from the Department of Rheumatology. She's working with the patients with vascularis and also connective tissue diseases, which put them to risk for pulmonary arterial hypertension. And she's going to talk about PEH associated with connective tissue diseases, most vulnerable group of PEH patients.
Thank you for the kind introduction. Yes, I'm a rheumatologist, and in the next few minutes I'd like to discuss with you PAH in patients with systemic autoimmune diseases. As you probably know, we recognize several systemic autoimmune diseases. They could be grouped in several groups, and connective tissue diseases are most closely associated with PAH. In fact, we already heard that different classes of pulmonary hypertension exist, and if we look closer to different connective tissue diseases, we can see actually that not every type, every class of pulmonary hypertension is present in individual connective tissue disease, but in each connective tissue disease, actually PAH can develop. Actually, connective tissue disease, PAH, is the second most frequently observed PAH in the Western world. And the systemic sclerosis has the highest risk of, those patients have the highest risk of developing PAH. In China, in South Korea, SLE is the most frequent disease associated with the PAH. Patients with connective tissue disease associated PAH have much worse prognosis in comparison to idiopathic PAH. What's the reason? Actually, they have a background disease that could affect also heart and other organ systems, and also perhaps other mechanisms could be important and could be also associated with the worst prognosis. The recent meta-analysis that included more than 14,000 patients, among them more than 5,000 patients with connective tissue disease, reported that the survival improved in the last years. Nevertheless, our patients have worse survival in comparison to idiopathic PAH. Pathogenic mechanisms are similar. Also in connective tissue disease, PAH, we see endothelial dysfunction and vascular remodulation, but also inflammation is important, probably from the initiation and through the progression of PAH. We treat our patients similarly as idiopathic PAH, but in addition, we also should think about immunomodulatory treatment, particularly in SLE and mixed connective tissue disease. Some patients respond quite nicely to immunosuppressive, immunomodulatory treatment. Let's have a look now at different systemic connective tissue diseases. First, systemic sclerosis. The incidence in Slovenia is between 2 and 3 cases per 100,000 adults. It is a disease that is characterized by fibrosis, vasculopathy, and inflammation. Actually, we recognize 2 disease forms, limited cutaneous and diffuse cutaneous systemic sclerosis. And as you can see, the survival of those patients is quite poor. The median survival is 12 years. And pulmonary hypertension, pulmonary arterial hypertension, is one of the major causes of increased mortality in those patients. 30% of SSC deaths are related to pulmonary arterial hypertension, and risk factors for developing pulmonary arterial hypertension are listed here. So several antibodies, also telangiectasias, ischemic ulcers, long-standing disease, male gender, and older age are all associated with increased risk to develop pulmonary arterial hypertension that is more frequently observed in limited cutaneous systemic sclerosis in comparison to diffuse cutaneous systemic sclerosis. Overall, the prevalence is estimated to between 8 and 12% of patients. Mixed connective tissue disease is somewhere in between. It's a rare disease, but has clinical features of several connective tissue disease. And in fact, 1/5 of patients actually finally progress to another well-defined systemic autoimmune disease. And those patients are characterized by special antibody that's anti-U1 RMP. Also in mixed connective tissue disease, we can see pulmonary hypertension. The prevalence is between 2 and 3%. And as you can read, actually patients with mixed connective tissue disease develop pulmonary hypertension quite early in the disease course. Also, it is an advanced hypertension at diagnosis, and the risk factors are listed here. And I was quite surprised that those who smoke have worse prognosis in comparison to no-smoking patients. Systemic lupus erythematosus is a prototype of connective tissue diseases. It has very heterogeneous clinical picture. We see many autoantibodies in those patients. We don't have the incidence for the Slovenia, but in Europe, in Germany, in Austria, the incidence of SLE is around 5 cases per 100,000 adults. And pulmonary hypertension can develop also in SLE, and it is listed among rare disease manifestations. In fact, the prevalence in the literature is between 1 and 5%. Risk factors are Raynaud phenomenon, serositis, and certain antibodies. And as I already mentioned, half of patients actually respond to anti-inflammatory treatment. And finally, Sjogren's disease. This is autoimmune epithelitis, mostly glandular, extraepithelial structures are involved and glandular tissue. Extraepithelial clinical feature is a consequence of B-cell hyperreactivity, and the most frequent disease manifestations are listed in the table. Pulmonary hypertension, it's not a typical feature of Sjogren's disease, but it can develop in around 0.5% of patients, mostly younger patients with anti-SSB antibodies develop pulmonary arterial hypertension, and there's no correlation with the systemic disease activity. How to screen our patients for the systemic sclerosis, where we can expect early pulmonary arterial hypertension? Actually, we screen every patient at the time of diagnosis and then yearly by algorithm like Dept or ACAG. But in other patients, actually, guidelines recommend just if patients are symptomatic, then to perform echo. So in summary, as a rheumatologist, I have to think about developing pulmonary arterial hypertension in my patient, then to suggest right tests at the right time, and I think that we need a multidisciplinary approach, and I think that we are cooperating quite good. So thank you for your attention.
So the last speaker is Assistant Professor Janez Toplišek from the Department for Cardiology. We have been working with him for quite several years now, and we want to thank you. When we get your result from ECHO and there's the sign of your name, I think I get a smile on my face because I know that I'm going to get an answer for my questions, and you've helped us for so many years when we didn't know who to put to do invasive diagnostics or not. So I'm thanking you for that. And you're going to have a speech on role of cardiac echocardiography in early detection of pulmonary arterial hypertension in patients with connective tissue diseases experience from our specialized center. Thank you.
Thank you, Polona. So, dear colleagues, I will discuss, explain the role of echocardiography in detection of pulmonary arterial hypertension. So, as you know, pulmonary arterial hypertension is a severe complication of scleroderma, and from the previous analysis in the past, the delay between diagnosis and symptoms was 4 years. Now, even in the latest guidelines, it is more than 2 years, and unfortunately, the majority of patients get in the advanced NIHA class, like 3 or 4. The pulmonary arterial hypertension is not the only disease in these patients. We have to, as cardiologists, we have to think about heart failure that is in combining with hypertension. One quarter of the patients die from this. And when the disease develops through the years, 1/3 develop systolic dysfunction. And if we do magnetic resonance imaging, about half of the patient has signs of fibrosis. So importantly, if we do just a conventional echocardiography, we can actually miss fibrosis that is, can be seen on magnetic resonance. We screen every systemic sclerosis patients and also the patients with scleroderma features, like mixed connective tissue diseases. This study was done more than 10 years ago and showed that it is worth to screen early, and we can improve the outcome of the patients. In the latest analysis, it was proven that survival can be improved, at least in the patients less than 70 years old, by modern approaches. So we proposed echocardiography algorithm that every patient should be first seen in our institution, the first diagnosed patient with systemic sclerosis or scleroderma features, and then the next, after 1 year, should be done in every patient that has either elevated BMP or reduced diffusion or tricuspid regurgitation velocity that is in the range of 2.8. So the next controls could be done in regional cardiologist departments yearly. But if there is some clinical worsening or occurrence of any this above criteria, the patient should return to our center. A little bit of echo criteria for diagnosing hypertension. They are actually the same as in the guidelines, the previous guidelines. Nothing changed in the range of the velocity, and this is this additional echo parameters that we always look. The only new thing is here sorry, it's not working. It's maybe the aorta, the pulmonary artery, if it is bigger than aorta, and the newest ratio, TAPSE through SPAP. Other things are the same. So we routinely look to every this aspect when we evaluate these patients. So echocardiography has quite a number of pitfalls. Actually, all the screenings have limitations. Regarding the numbers, these numbers that are borderline can be false positive in the half of the cases. However, even the best accurate screening test can miss some percentage of patients. Therefore, as the only method, echocardiography is not sufficient for screening mildly symptomatic or asymptomatic patients. However, also the right catheterization is not sufficient for diagnosis, for instance, heart failure with preserved ejection fraction, since we need some evidence of structural heart disease, like doing with echo or magnetic resonance. So at the end, I will present our data from last 9 years. We examined almost 290 patients, and we found 6% of them having pulmonary arterial hypertension. So this is the most prevalent form in systemic sclerosis patients. The next two etiologists were, the second one was post-capillary. It was almost the same percentage, and much less other precapillary causes like interstitial lung disease. Importantly, there is quite a big group of patients that have, let's say, some risk factors for developing pulmonary hypertension, like heart failure, but without pulmonary hypertension at rest. One patient had a real dynamic form of precapillary hypertension, so not obvious in the resting conditions, and a very big, actually, group of patients that had really high normal pressures. So let's say around mean pressure around 20, a little bit less, a little bit around this. And so we ended with 70% completely normal patients with no normal pressures. So if we compare this to the literature, we can see there are probably some percentage of patients that are missing. Otherwise, the percentages are quite similar. We work with cardiology patients, so probably maybe we are even better than in literature, finding the patients with post-capillary hypertension. So the annual incidence of pulmonary hypertension in total is about 1.6%, so meaning about 5 patients per year. So if I compare the data from 2 years ago, I can see that we have maybe a little bit less real patients that we need to find. Maybe it's a reason also the COVID. And we found much more patients with post-capillary pulmonary hypertension. So I would say that maybe a few patients might be detected by the right catheterization still. So in the end, I will briefly just inform you what actually tests we perform. As a standard echocardiography, we add to all our patients measurement of longitudinal myocardial deformation in both ventricles. And in any doubt, we use contrast like gelatin to see the optimal envelope of tricuspid regurgitation. Regarding the function, I would stress that we should do more cardiopulmonary exercise testing, because it is quite helpful to, let's say, to see the borderline cases and to see the markers of ventilatory efficiency, and this can guide us maybe to another tests in addition. Any other tests are used as it is needed. So in conclusion, the screening of pulmonary arterial hypertension allows us to see patients earlier, maybe already still asymptomatic or really mildly symptomatic, and we can improve their prognosis. As each screening has its own drawbacks, it is useful to use multiple criteria to be really efficient. And at the end, patients with pulmonary arterial hypertension with scleroderma should be treated in expert center, and specifically more patients with borderline pulmonary pressures should be evaluated by CPET, so cardiopulmonary exercise test, and invasive right catheterization to find a little more patients that we still have to find. Thank you.
So we finished now the first session. I just want to make a little point, because we found a little mistake in one of the slides. So the diagnosis for pulmonary hypertension using the latest guidelines is mean PEP of 20 with a PVR more or less than 2. And there is now not an agreement to start treatment from 20 to 25, which was the previous definition of pulmonary hypertension, but still looking at these patients who are really have a poor prognosis, I think we have to be really careful and following them up quite severally. I mean, not to let them out of our sight, to start treatment then as soon as possible, because these are the patients that progress really quickly. So opening the discussion, do we have any questions?
Hi. Okay, so I would like to ask Professor Cvijić the same question as I did for Galie. Do you think the development of the modern technology, maybe in the recent future also with the artificial intelligence, will enable us to see the real diagnosis sooner and with less invasive procedures? I think your talk is pointing to that direction.
Yes, thank you for the question. I think you should not be worried that you will not have work, definitely. I think that we will be easier to find patient with post-capillary pulmonary hypertension and maybe not send this patient to the right heart catheterization. With this provocation test, it's a little bit easier to find this kind of patient. But we need, I would say, bigger study to really see if we can use it. Now it's on the research basis, and none of the guidelines recommend to skip right heart catheterization due to the echo if you are in doubts.
Yeah, I agree with that. But even this is very important. If we can, with a good certainty, exclude a patient that does not have arterial hypertension but has post-capillary hypertension, then this reduces the number of patients that ultimately have right heart catheterization. And I think we already did a lot in this direction, because from the data that was shown, I think from Dr. Lestan, we see that only 11% of patients with post-capillary hypertension pulmonary hypertension were included in the had the procedure.
Yes, I agree. I think this goes to very good echo of Dr. Toplišek, and we are continue with this practice. And I hope we could reduce the number of unnecessary right heart catheterization in our center.
Zdaj bomo imeli mi tudi, midve s Polono, imava pa še eno vprašanje za dr. Gorjupovo, če bi lahko prišla gor, ker se bi midve rade zahvalila. Najprej bi se jaz rada zahvalila dr. Gorjupovi, ker je to, da smo prišli do res take odlične invazivne diagnostike, njeno vodilno delo. Že prej se je malo tako, kot tiste male rožice na začetku raste, ampak z njo smo pa res dobili človeka, ki je za začetek takrat, ko se je to začelo resno delati, bil vedno pripravljen in stal ob strani pri najtežjih bolnikih, in to se jaz osebno zahvalim. In potem se je pojavila Polona, ki je bila ena taka res neverjetna, zagnana mlada zdravnica, ki je to prevzela, srcem se učila, in one dve sta, tako da jaz bi se njima obema zahvalila, ker zdaj predajam, sam imam tamle rožice, Andreja mi prinese. Ja.
No, še jaz povem. Ja, še enkrat najlepša hvala. Ful smo veseli, da ste nas naučili vse, kar ste nas naučili od samih začetkov do tega, da jih imamo zdaj skoraj že proti 100 na leto. Smo ful ponosni na to. In ne bi zmogli brez vas. In pol, ko greš v tujino in vidiš, kako delaš, si ponosen, ker delamo res 1A top. Tako da, ful hvala.
Lahko sam jaz še nekaj povem, tako po enih 20 letih, ko sem to delala, sem rekla pa, a ni že čas, da se vi naučite, in Barbaro prepričevala, da to pa je nujno, in zdaj imajo pa itak nove prostore, pa se da, in potem se je pojavila Polona, ki moram reči, da je bila res kasonček, celo s takim trebuhom je prišla, če smo imeli pacienta, pa sva skupaj naredila kateter, tako da ja, sem bila zelo, zelo srečna, da sem lahko tudi ta del svojega dela predala mladim pulmologom še naprej. Hvala lepa za povabilo. No? Hvala lepa.
We are sorry, we forget. We speak in Slovene, so we were emotional because we say thanks to our Dr. Gorjup, who really teach us how to perform correct invasive diagnostics, and to Dr. Mlakar, who is now the #1 together with Dr. Lestan.
So to get back to discussion, does anybody have any questions left? Or maybe on Slido, online? So we'll have a short break of 10 minutes and we'll get back. At a few minutes before 1 o'clock, right?
Co-host bomo napisali. Okay, cool. Se še ni zares, se mi zdi, da je še...
Lahko? Lahko? Yeah. Dear all, after a very successful first part, when we talk about the proper diagnostics of pulmonary arterial hypertension, we move on the second part, where we will talk about modern management of pulmonary arterial hypertension, and it's really a great pleasure to introduce Professor ERN-LUNG from AKH Vienna. She is most famous, important expert for this field. And it is a really great honor for us that she helped us, Professor Galie, all these years, since we have got all the drugs for specific drugs for pulmonary arterial hypertension. She helped us with her expert opinions, with lectures. He teach us, he invite us to AKH Vienna, so we get really a lot of knowledge. And so, Irene, I would like to, before we start, really from my heart thank in my personal name and in the name of all for all your help during all this year since 2003 when drugs, specific drugs, also oral, were approved for the treatment. And Professor Lang will talk about... You don't hear?
Yeah, she's talking to us.
Okay. Yeah. Thank you. And she will have the main introductory lecture to this part of our meeting. Thank you, Irene.
Well, thank you, Barbara. It's a real pleasure to be here. I'm so sorry. I just see you, but I cannot see anybody else. So I still send my best regards to Polona and to the patients and to all the other physicians who I've met. It's really very, very gratifying to work with you and your patients. I remember many and maybe all of them, and I really have enjoyed working with you. And the topic you gave me is really good. You know, I like it a lot because it's where I started from, it's where we came from. And I hope I'm not too long with my presentation. I will be trying to make it simple and concise. Let me move on my slides. This is my conflicts of interest. So I'd like to start here because you're saying, where did we come from? And I submit to you that pH comes from the interest that was risen by anorectic drug side effects. And that's the first study that I have in my computer that reports the l'hémodynamique de l'hypertension artérielle pulmonaire d'origine vasculaire. And this was really based on the observation that an amphetamine derivative that was taken to shape up the body and be slim and energetic caused pulmonary hypertension. And you see that started right when I was born. And in the 582 cases that were collected in this cooperative retrospective study, more than 2/3 had a history of some anorectic / amphetamine intake. And the drug that really dominated the market here was minoxidil, aminorex fumarate, an amphetamine derivative, central stimulant, by that way causing weight loss. And you see it was introduced in the DACH region in the 60s and then withdrawn in October 1968. And had already left a lot of deaths behind, and was the stimulus for the first World Symposium. I was not personally there, but I have the little monograph, which is a green linen book. And you can see here that the community there was 17. Henri Denoleur, Alfred Fishman, Heinz Gurtner, Harris, Lentfand, Wagenfurt. And they wanted to clarify what is pulmonary vascular disease. Can we collect data on pulmonary artery pressures prospectively or retrospectively? Let's develop non-invasive screening. They already dreamed about non-invasive screening. And what about the registry? And they were successfully putting together this registry, and the first main insight was that mean right atrial pressure and cardiac output were significant predictors of outcome. And from there on, we moved towards treatments, and prostacyclins came in via John Vane. You know the story about prostacyclins. And prostacyclins made already the first difference for decades. Still, 60% survival at 3 years was not fantastic, but much better than the expected survival based on the NIH registry. So this was parenteral prostacyclin. In the Second World Symposium in Evian, where I already went by train, there were 100 people. And I remember the domineering role of Stuart Rich and Lou Rubin. They really ran the show. And it was a very interesting meeting for me because I heard about calcium antagonists and the responder status and about lung transplantation, which was very important then. And about the same time, and a little before that already, lung transplant had started in my city. And you know, I'm talking about Vienna lung transplantation program because Walter Klepetko really was a pace setter for lung transplantation in Europe. And they had very good success. And simultaneous, the first self-support groups, and this is the example of the Austrian self-support groups, but very simultaneous all over the main countries, patient self-support groups for pulmonary vascular disease emerged, both in the pediatric and in the adult environment. The third meeting was in Venice and was already very organized. 200 people were there. There were 6 organizers and 100 members of task force, and the task force system has been kept until today. And there was the main news was the discovery of mutations, loss of function mutations in the pathway of TGF-beta repair mechanisms, and the most prominent was the bone morphogenic protein receptor 2. And at the time, the term primary pulmonary hypertension was finally banned, and 3 classes of drugs emerged. And it was already shown then by Nazzareno, who you heard today, that these 3 drugs actually improved outcomes. The survival was better if you were treated. There was a 40% reduction in this meta-analysis. And the 4th World Symposium, the group met in the United States, in Dana Point. And it was very clear that the community was increasing. 350 people were there. Industry played a main role, which is good, I always think, but people think different. And there was more genes discovered. And for the first time, the problem of the other PH comes up. PH left heart disease, PH lung disease, and CTEPH is also in the mainstream. And let me show you about CTEPH. We had started the program in Austria in 1992, where surgeons take out vascular obstruction in group 4 disease, and survival was really excellent. You see the red line, this was the European CTPH registry that emerged about actually already earlier, it was founded in 2009. There were other patients who didn't do so well, but let me wait and talk to you about more world meetings before we focus on the blue line. The 5th World Symposium was in Nice in 2013. Big community, over 1,000 participants. And it was really the first time that the voices were heard asking for large registry data, including biobanks. So this was the birthplace of the PBDomics idea and the NIH, the British National, the UK Biobank in terms of pulmonary vascular disease. We had already 12 task forces working hard for several days and the months before. And the paper was, actually published in the JAC, where the achievements of the groups were summarized. It was very clear then that progression was bad in this condition, and the monotherapy, still at the time of the AMBITION study, illustrated a high mortality rate. And AMBITION made a main difference at this time, showing that if you add 2 drugs in the very beginning, people do better. And combination therapy was not anymore discussed strategy. So you can see here the primary analysis set with the change of walking distance and NT-proBNP. Very clearly positive study, has never been refuted afterwards. So what about CTEPH? At the same time, we moved on, but we knew that half of the patients weren't candidates or didn't undergo pulmonary endarterectomy. So in 2014, April 28, we started BPA, and it's an unforgettable day when Matsubara came the first time to Vienna and taught me about PEA versus BPA, the 2 completely different strategies of approaching patients with pulmonary vascular disease of the obstructive type. And you can see here an opening of left anterior, of the left A1 segment, and the final result. And subsequently, the blue curve came up, almost equal to the red curve. So we will hear this data later this year. Not operated patients are doing much better today because of the combination of pulmonary endarterectomy, because of BPA, because of the use of medical treatments in this condition. In the 6th World Symposium in 2018, there was a new definition of pulmonary hypertension, also of pulmonary arterial hypertension. So the mean pressure greater 20, and for pulmonary arterial, we had to have a PVR greater 3 Wood units. That was actually also published in the European Respiratory Journal, and much discussion at this meeting was on the term PAH with comorbidity, atypical PAH, and basically the other groups. And it's very well recognized that age is increasing. It's a reality. And why is it increasing? It is increasing because patients with PAH get older. And it's increasing because patients with left heart disease and lung disease get older. And PH occurs in these patients as a real serious comorbidity. And you can see here on this old global view that I think is very valid. Lung disease and heart disease are the predominant types of PH. I would even say lung disease is overrated here. It's left heart disease is really taking over. And the upcoming 7th World Symposium, you see, we will have 15 task forces to discuss progress in pulmonary vascular disease. And I think it's a very, it will be very interesting. There will be new insights coming from this meeting. And to move into this world meeting, it's important to ask the question, how are we dealing with PAH today? We've learned we probably need a prostacyclin, and we also need upfront combinations. And let me show you an approach that is very valid today, and that is focused on the right heart. And you can see the guidelines treatment algorithm. I'm not going to go into this very explicitly. There's a 3-strata risk assessment that we are using for the first step, and after 3 to 6 months, we use a 4-strata risk assessment for the next step. But what have we learned in the 10,000 patients that we have treated within 46 published randomized controlled trials and outside of those? We have learned that we cannot be satisfied because the majority comes late. But Professor Galie and other speakers have addressed the question of diagnosis, and patients still do not survive as we want them to. There's still a 5-year survival rate of 60%. Well, there was a 3-year survival rate of 60%. Now we are at a 5-year survival rate. But you know, if you have children, 2 years is nothing. And you can see here that while the initial treatment uses have been improving survival, we are basically remaining at a level average, not satisfactory. So we have 3 routes of treatment that are mainly vasodilators. Well, all are vasodilators. And in the path of patients from their diagnosis to that death, there's a number of drugs on the way, and you can see the survival has been improving, particularly with the combination, we've said that. But have we actually changed a lot in the terms of PVR? No, we haven't. And what does it take? Well, it takes 50%. You have to, with vasodilators, decrease pulmonary vascular resistance by 50%. This was nicely shown by the Italian group. The likelihood that the right ventricular end-diastolic area normalizes is in a very clear parabolic relationship with PVR decrease, and that is shown on the slide. And there's a group of European pulmonary hypertension experts that recently got together and has mandated a more aggressive approach of upfront lowering of pulmonary vascular resistance. This thought has been supported by the data from the French registry. This slide shows intermediate low risk at baseline patients who were treated with either 1, 2, or 3 drugs. And you can see that the ones who had triple therapy at the beginning were the long-term survivors. Even more outspoken is this observation with intermediate high risk at baseline. And the Canadian registry has recently replicated this data by showing the triple survivors with the best outcome. And finally, there's a recent publication of the Japanese investigators illustrating that even better than oral combinations are combinations including a parenteral prostacyclin. And they used a mean pulmonary artery pressure-based approach. So I do think that we have learned many things. First of all, we've learned to understand what is pulmonary vascular disease. Unfortunately, by the example of a drug side effect. And second, we have learned how to treat. And a proposed future treatment strategy is shown on this slide. And you see that we have started to do combination treatments. We have also brought into our portfolio the need to do a 3 to 6 months follow-up, including invasive measurement, re-stratification, and then, depending of whether you're low or intermediate low risk or intermediate high risk, move on from there. My mandate is you have to reach low. If you don't reach low, I don't know what to do, but experts know, and they publish in Lancet Respiratory Medicine. You continue treatment if you are green. You consider adding sotatercept if you are yellow, and other pH therapies. And if you are higher risk, this is what you do. You consider sotatercept or intravenous prostacyclins. So I haven't spoken about sotatercept here because it's one of the most recent additions to the armamentarium of pH drugs. It's a non-vasodilator drug. That's what we know. It seems to be modulating the BMPR2 pathway or the ALK1 intracellular SMARTs, but nobody really knows exactly what it is doing. It is incredibly efficient in terms of improving 6-minute walk, and the time to clinical worsening is shortened, and there's much less clinical worsening. But still, we need to watch. I think there's one study out there, this is Stella, under the leadership of Marius Höpp, who is very much promoting the drug. And we are very grateful that there is a symptomatic improvement that can also be documented on the right ventricle for patients with PH. But we still need to see because of side effects. So let me summarize my presentation, where we came from. We came from where I was born, really. This is funny. I'd like to emphasize that drug side effect has triggered the interest in PH. In 1968, 55 years ago. Initially, the only drug was parenteral prostacyclin, which is still a good drug, but it's not so easy to handle. Prognosis has much improved since the introduction of PAH-specific medications. That's very clear, and we are very proud of this. We have had particularly excellent success using the multimodality treatment of CTEPH, including PAH drugs in that, particularly riociguat and some treprostinil, and also BPA, of course. However, there is an unmet need to improve the management of PAH as it stands today. One target is the RV, and we can use vasodilator drugs in a hit-hardened early strategy because it is better than goal-oriented. Please, let's watch sotatercept together. Thank you, and I'm really happy to answer questions if I can. Thank you.
Can you hear me?
Can you hear me?
I can hear you. Can you hear me?
Yes, yes.
So I have, can you hear me?
Yeah, now it's working. Okay. Hello, Polona.
Hi. So I have one question. In the new guidelines, there's a PEH with comorbidities. Mm-hmm. So more and more patients are older, they have ischemic heart disease, they have lung disease. And I'm thinking if they have like important pulmonary hypertension with high PVR, how aggressive are you in the treatment? Because the guidelines say monotherapy, they get off therapy a lot, they have a lot of side effects. Do you treat them aggressively if they're good responders?
That's a great question, Polona. It's really, I think, the question of the today's PH, because many patients are not in the group 1. I would say, number 1, please exclude CTEPH. Number 2, please be sure that there is no left heart disease and no lung disease. And if there is, please treat those first with all you have, including defibrillator, CRT, JAD ions, atrial fibrillation ablation, renal replacement, I don't know, okay? Number 4, please do a very good right heart catheter where you assess pulmonary vascular disease. And if this is the case and the patient is going to the hospital for right heart failure, please treat. And I personally, in these rare cases, use prostacyclins.
You do. Yes. We start slow with the peroral therapy, but then if the responders, I mean, and all that is covered, what you said, we are also thinking about giving them treprostinil. Yeah. Any other questions?
We'll be showing, Roella is preparing, and Nika are preparing data on prostacyclins for group 2 and group 3.
Great. Any other questions? Barbara has a question.
Yeah, thank you. So you really have a nice presentation, and I would like to ask you once again, because I think you explained this so nicely. So how to differentiate? We can have, for example, we can have interstitial lung disease and left heart disease.
Yeah.
And we can have idiopathic pulmonary hypertension and left heart disease. In addition to have this out of proportion pulmonary arterial this combined pulmonary hypertension in patients with left heart disease. So is there already a place to decide it? That patient has two diseases and start specific drugs. Are we allowed to try sometimes to do this? And how you approach? Because I know you have a lot of experiences with this. It's very similar to the question
of Polona. You know, the guidelines are saying if you have a patient with obvious non-group 1 disease, you know, I hate the term PAH with comorbidities. I hope they get it out of the guidelines soon. Because if you look close, it's either PH left heart disease or PH lung disease or PH combined left heart and lung disease, many times, right? So the guidelines open up individual decision making, and you have to justify for your payers why you're doing this. So my approach would be, number one, which is the disease and which is the comorbidity? And for this, you have to go back to the patient history very carefully. If you have a patient, 72 years old, has had bypass surgery, has had atrial fibrillation ablation, has a pacemaker, has amyloidosis, has, I don't know, you know, has dementia, right, or diabetes, very severely ill, and then has very severe PH, I submit to you that the other conditions are his underlying conditions. If you have a patient with PAH, you put the person on prostacyclins, and this was 23 years ago, and now she has broken her hip and has aortic stenosis and has fallen because of syncope. Then she has PAH with left heart disease now. Then it's probably the left heart disease, the comorbidity. And she, because she will always have PAH, she was diagnosed with PAH 23 years ago. So I think we have to be really careful in our individual judgment. Okay. The bad thing about the guidelines is the confusion with the term PAH with comorbidity. The good thing about the guidelines is that they open up for personal decision making. If you are saying, I have a patient here who has very severe pulmonary vascular disease, and I cannot decide whether it comes from his underlying condition, which may be prostate cancer, or whether it is new PAH, then the guidelines let you administer drugs because you decided. So the PVR above 5 Wood units has been defined as severe PAH in the new guidelines, which is also helpful because all these patients very often have higher than 5 Wood units when you think about a treatment, right? So I think it's a very complicated subject. I hope that the World Meeting will help clarify. I've put in a request to have a chapter on PAH with comorbidities. please get it out, clarify the approach, define comorbidities, define the timing of the PAH versus the comorbidity. I think it's very important.
Super, yeah.
Not a new condition.
Yeah.
It's always been there.
Yeah. And because may I ask you also, because you will not be able to be with us in the next lectures, just your opinion on sotatercept?
I think sotatercept is a very new concept of drug in pulmonary arterial hypertension because it is clearly not a vasodilator. It's not intervening with the calcium metabolism in the cell. All the others are, right? It's a drug that works on the BMPR2 pathway, actually on the TGF-beta pathway, I should say. It's a ligand trap for the ALK1 receptor. And I think it really works. What I'm very certain about, and you are certain about, it increases red blood cell count. So it improves tremendously tissue, oxygen delivery to tissues, muscles, heart, everything. So I think patients get much better. It is in that regard a real innovation and improvement. On the other hand, we don't really know how it works. We don't know long-term effects. We don't know what side effects will be doing to patients, how severe will thrombocytopenia be, how much bleeding will occur. What about the telangiectasias? Do we worry about it, or are there sources of bleeding in the GI tract? So I think much is open. I'm a little hesitant to see sotatercept as a new wonder drug. I don't see it that way. I want to see how it behaves in the future. And I think the first effects are excellent, but we are experienced physicians and we know that we have to wait some time to really appreciate.
Okay, thank you. Any questions more? Is there any on Slido? No. Okay, is the next one? Yeah. So Irene, really, Professor Lang.
Thank you for having me be here. I hope it came across. And next time maybe I can come. It's
we really wish. We planned already. Okay, we already planned after the seventh World Symposium, and then we will meet. Thank you so much that you will be.
Thank you also, and enjoy the afternoon. Thank you.
Thank you. Bye.
So since Professor Asen-Ristic couldn't make it, we are going to carry on with Assistant Professor Nika Skorosajer. She is also working at AKH Vienna, and she will have a speech about parenteral prostacyclins, still the most effective therapy for PEH. Nika, can you hear me?
Hello, everybody.
Hey.
I'm going to try to share my slides. So looking forward to see you, everybody, although online, but somehow it doesn't work. Maybe now? No, still not. Do you see my slides? Hello?
Yes, we can see your slides.
Yes, great. Okay. Very happy to be the part of the symposium. I am unfortunately online, but next time, as discussed and promised, we are going to visit you in Porto Roche. This is the plan, fixed plan. So my topic is parenteral prostacyclin, still the most effective therapy for PAH, which is a very complex topic. And I'm not sure that I'm going to be able to put everything in 20 minutes, but let's try. So pulmonary hypertension is a major health issue affecting all age groups, and prevalence is around 1% of the global population. And you already heard Professor Lang told us that the left heart disease is the leading cause of pulmonary hypertension. The second most common cause is COPD. On the right-hand side, you see hemodynamic definition, which changed last year, 2022, actually by lowering of cutoff values of mean pulmonary arterial pressure from 25 to 20 and PVR from 3 to 2 Wood units. Well, pulmonary arterial hypertension is characterized by pulmonary vasculopathy with typical changes, intimal proliferation, fibrosis, medial hypertrophy, also thrombosis, in some cases plexiform lesions. And underlying these vascular changes is the dysfunction of 3 signaling pathways. It is endothelin-1, nitric oxide, and prostacyclin pathway. So vasculopathy promotes an increase in PVR, triggering right heart afterload, overload, and can lead ultimately to right heart failure. Still, we know that PAH pathophysiology is multifactorial, and probably immune and inflammatory processes or factors are involved. In the past decades, a significant progress in the treatment of PAH has been achieved. On this slide, you can see the timeline of approval of the PAH drugs. And since 1995 until 2015, 10 different compounds were developed and tested for the efficacy. And today we have 10 potential treatment options for treating PAH. Of these are 3 prostanoid or prostacyclin analogs, epoprostenol, treprostinil, and iloprost. Despite recent advances, PAH remains still a fatal disease, and of course, efforts to slow the disease progression are essential, and also further research is ongoing to develop therapies for novel modes of action. Since 2015, guidelines recommend treatment decision based on comprehensive risk assessment. At baseline, it is actually a multi-parametric approach using a 3-strata model. 3-strata model should be used only at baseline. And this allows us to discriminate 3 groups. A group with low risk for 1 year mortality, which is below 5%, intermediate risk 5 to 20%, and high risk patients have a 1 year mortality greater than 20%. So what do guidelines actually recommend? You discussed already with Professor Lang that the guidelines discriminate 2 patient groups, patients without and with cardiopulmonary comorbidities, but I'm going to focus only on patients without cardiopulmonary comorbidities. And we all know that patients who are at low and intermediate risk should, based on the data from Ambition and Seraphim trial, be treated with combination oral treatment, initial ERA and PDE5 therapy, and only patients having high risk at baseline should be treated with combination therapy, oral, ERA and PDE5 inhibitor, and IV or subcutaneous prostanoid. And this is a class 2A recommendation. At follow-up, we should use 4-strata model. 4-strata model is actually more sensitive to changes in risk, and it better discriminates intermediate group into 2 further groups, intermediate low and intermediate high risk. So what should we do at the follow-up? Of course, all patients who stay or who move to low risk group should continue with initial therapy. It is class 1. And patients with intermediate low risk should have some changes. Probably you can add either Selexipac to the dual treatment, this is class 2A, or switch PDE5 inhibitor to riociguat, class 2B. Patients who are intermediate high risk or high risk should be evaluated for lung transplantation, and we should in this patient add parenteral prostanoid. So prostacyclin was discovered in 1976 by John Wayne and colleagues, and this gentleman actually received Nobel Prize in 1982 for this very important discovery. And you see the original speech translated from Swedish, that actually, but this discovery Wayne provided an important weapon for those continuing the research directed towards establishing the functional role of prostaglandin system. And it is indeed, he gave us really important weapon, especially in the field of pulmonary hypertension, how to treat these patients. Prostacyclin is produced from arachidonic acid in multi-step process, and in pulmonary circulation, prostacyclin is released and produced in the endothelial cells by prostacyclin synthase. Thromboxane is also an arachidonic acid metabolite, and these two actually prostanoid is IP receptor, which activates adenyl cyclase and cyclic AMP, leading to vasodilatation. Also, prostanoids bind to many other receptors, and they activate diverse signal pathways in a range of multiple biological responses. So on this slide, you can see routes of administration. And you see that the prostanoids can be given by inhalation, orally, intravenously, or subcutaneously. And of course, we know that on all organs we have receptors for prostanoids. And therefore, some adverse events are very typical. For example, activation of IP-DP1-TP receptors on peripheral systemic artery lead to flushing and headache. Also, activation of prostanoid receptors on nerves can result with jaw pain and pain in the extremity. And very typical adverse events activating receptors in gastrointestinal tract, leading to diarrhea and nausea, especially in patients on very high doses. So the physician who starts this treatment should and must manage, of course, adverse events to reduce the risk of treatment discontinuation. But combining data from all prostanoid trials, this is a meta-analysis by Professor Galie, supported improvements in mortality, exercise capacity, clinical worsening, and also hemodynamics in all patients ever treated with parenteral prostanoids. However, this actually study shows that the use of parenteral prostanoids is underused or not that frequent as we would wish. Among 3,500 patients in REVEAL, the patient cohort who died was analyzed, and there were 487 patients who had a PH-related death. And in the larger set, 908 patients died from any other causes. So when we focus on patients who died, actually only 43% were treated with IV prostacyclin before they died. And also patients who reported as having functional class 4 at the last follow-up before they died, only 58% were on parenteral prostanoid. So this study, I think, really reflects reality, unfortunately. And indeed, parenteral prostacyclin treatment were not or is still not consistently used in the most seriously ill patients based on this data in the REVEAL trial, and especially not in patients who were in functional class before at last follow-up. But the relationship between the initial therapy and survival in PH was uncertain until Buckley actually published this data, focusing on big group of patients, 1,600 patients with PH, as IPH, heritable PH, or anorexigen-induced PH, who were enrolled in French registry. And indeed, they could show that the small group compared with other groups of patients who were on triple combination therapy initially, including prostacyclin analog, had significantly better survival rates compared with patients who were on dual combination or on monotherapy. When these patients were stratified according to the initial or baseline risk assessment, similar data could even more differentiate these two groups. Patients at high risk had terrific survival rates, around 90% compared with patients without prostacyclin and on combination, very similarly also in intermediate risk patients. So let me show and share with you our experience, Vienna experience, since 24 years, since I've been working on in pulmonary hypertension outpatient clinic for many years, and I actually was involved in putting the first patient on the pump. So since then, we performed prospective registry to evaluate the long-term effects of subcutaneous treprostinil on, of course, functional class, 6-minute walk distance, hemodynamics, and survival in patients with first line subcutaneous treprostinil and severe precapillary pulmonary hypertension. And since then, 141 patients were included. You see the dose increase over the years. This was only group 1 or PAH, and the most of the patients were in functional class 3. And in some of the patients, we actually use sequential treatment, putting patient sequentially on subcutaneous treprostinil or as an upfront treatment, either mono and then over the time combination therapy. So what we could actually show is that the subcutaneous treprostinil I don't see my maintain and showed improvement over the years on exercise capacity over 7 years. You see the red boxes are showing increase in 6-minute walk distance, and blue line is showing dose increase over the years. Very similarly, mean pulmonary arterial pressure decreased over the years. Of course, there is a bias because not every year, every single patient undergoes a right heart cath, and also very similarly, over the time, a long-term effect of subcutaneous treprostinil by increasing cardiac output. So those are actually when we stratify retrospectively this patient group, of course, according to the assessment, we could realize that the most of the patients were actually at intermediate risk, around 82, not around, but 82 patients compared with high-risk patients, there were only 43. Of course, when we compare these two groups, you see significant differences in functional class, in 6-minute walk distance, in NT-proBNP. Interestingly, pulmonary arterial pressures were very similar in both groups. Mixed venous saturation was much lower in high risk, and PVR was actually higher, but not significantly significant. Cardiac index was also lower. So when we actually retrospectively analyzed, we realized that we treated not only high risk but also intermediate risk patients. When we or looked for survival rates according to the baseline assessment, we could actually realize that both groups, intermediate and high risk, have very bad survival rates. So they do not actually differ from each other. But at follow-up, again, retrospectively use of 4 strata model could confirm similar data to all big groups, French groups or Swedish group, showing that patients having low and intermediate low risk at follow-up had significantly better survival than those who were at intermediate high or high risk. We also look for, although it is of course a very small size, there are only 15% patients on sequential prostacyclin therapy. In the beginning, it does not differ either you give it upfront or sequential, but over the time, the survival of upfront prostacyclin treated patients was better compared with sequential. When I talked to Barbara, I promised to show also the data about congenital heart disease related PAH, because we know that the major drawback of IV treatment in this patient is need for permanent central venous access, which can also lead to systemic embolization because of right to left shunts and of course high risk of infection. So we actually collected the data from 3 centers from Bratislava, Budapest and Vienna, and included consecutive patients with congenital heart disease, either unoperated, previously palliative surgically, who were actually class 3 and 4. We used it even before Bosentan was approved, and also for patients who improved clinically and hemodynamically, but then they failed to improve furthermore on Bosentan, or because of discontinuation of a Bosentan due to adverse events, and of course for patients who were in function class 4. And indeed, subcutaneous treprostinil was actually increased to maximal tolerated doses. All patients were, of course, receiving conventional background therapy. And indeed, treatment with subcutaneous treprostinil was associated with an improvement in 6-minute walk distance after 6 and after 12 months. Also, a significant decrease of pro-BNP or anti-pro-BNP over the time. In 14 patients of about 31, we reassessed hemodynamics, and we found also significant drop in mean pulmonary pressure by 8 mm mercury, cardiac input and cardiac index improved, and PVR also decreased. Last but not least, subcutaneous treprostinil is one of the 2 approved drugs for inoperable CTEP. This is a trial in which also Slovenian patients were included. CTREF trial focusing on very severe CTEP patients, function class 3 or 4, and who had already cardiac decompensation, inoperable cases, of course, or cases with persistent recurrent pulmonary hypertension after PEA. And patients were randomized either to low or high dose treprostinil. On right-hand side, you see the change of the dose. The high dose was achieved after 12 weeks, and indeed, the primary endpoint begins to change after achieving the high dose. You see, after achieving 30 nanograms, actually, the 6-minute walk distance significantly improves compared with low dose. So also secondary endpoints improved. So subcutaneous prostacyclin is an approved treatment for inotropicity. We of course learned a lot about side reaction management, and we know that acute administration is associated with many significant side effects. Many centers do not succeed to put the patient on the drug and to treat for many years, because it is really painful. It is very red. It is a problematic, of course, for every single patient. And on this slide, you can see typical side reaction. Of course, diarrhea. We had also some abscesses, but treated with antibiotics, but it wasn't serious. It was never a serious adverse event. So you see also typical and atypical site injection sites, with very rare on upper arms and on belly, on the back side. So we started infusion site pain using questionnaires and pain visual analog scales, and we learned that infusion site pain is short-lived. It usually resolves after 1 week, approximately, after new injection setting, and it does not really correlate with the dose. Because of the concern of efficacy loss, we actually measured plasma concentration of prostacyclin, and indeed it was not affected by a longer period of leaving the needle or the plastic syringe in the abdominal wall. Actually, the dose was correlated linearly with plasma concentration. Last but not least, would like to mention the trial which we hope is going to change maybe opinion about subcutaneous prostacyclin, maybe the goal to really reach low risk with triple treatment. So in this trial, we should look for treatment-naive, intermediate, high-risk PH patients who never received any treatment, so treatment-naive, and they should be randomized either to double oral treatment or to triple oral treatment, double with subcutaneous prostacyclin. And the primary endpoint is achievement of low risk within 24 weeks and then week 48, or at any time when the patients actually achieve low risk. So we hope this trial is going to change maybe the thinking of prostanoid and the position of prostanoid, especially in the centers which do not use parenteral prostanoid. So what we have learned is that in Vienna, intermediate and high-risk patients have similar survival rates. And we think that we should actually distinguish only low-risk and non-low-risk patients, meaning that even intermediate risk patients should be treated with parenteral prostanoid. And our approach was always hit hard and early, using parenteral prostanoid to improve survival in intermediate patients. And of course, probably we cannot exclude that we underdose these patients because of side effects. Thank you very much.
Thank you, Nika. Please stay with us until the end of this session because we'll have a roundtable discussion.
Are there any questions, or we go on with the next lecture?
So yeah, we would like to ask you if you could stay just a little bit more until the end of the session, and we'll have a roundtable discussion for all the speakers of this section.
Of course,
except
but not
Irene,
immediately
because
after the presentation.
Irene, we already had the discussion with her. So next up is Assistant Professor Rosa Badr-Islam. She's also from AKH Vienna, and this lecture from Nika was a great introduction to this next lecture, which is better possibilities for long-term parenteral prostacyclin therapy with subcutaneous pumps, experiences from AK Havina. Rosa?
Yes. Hi, everybody. Thank you for giving me the opportunity to take part in your great session. I need a little bit time to connect myself. We did try yesterday and it takes me a little bit time, but it will be soon done, hopefully. But anyway, I sent my slides at noon. Maybe you can share and I can talk because the system is not able to connect. I don't know why.
We want to kindly ask you to try again to share the slides, if it is possible. The green button below and select share screen.
I do it many times, but it says not possible.
Can you perhaps try just one more time?
It doesn't let me go. Do you have the slides from noon or should I send you again?
Sorry, just give us a moment. We'll double check if we have your slides. Sorry, can you perhaps send the slides one more time?
Okay.
Thank you. Thank you. We have received the email with your PowerPoint presentation. We just need a moment to download it and set it up.
So I did send again, just...
Yes, thank you. We have received them. We'll just forward them so you will get a feedback image so that you will be in sync with the presentation. Thank you.
Oh, now it works.
Ah, okay. That also works, yes. you may take the floor.
Okay. So, sorry for this interruption. So, my part is a more technical part, and I'm going to talk about the pump options and how we manage the therapy in Vienna. We have heard from Professor Lung and Professor Skora-Sayer that parenteral prostacyclin therapy is recommended for high-risk patients. If we look at this therapy treatment algorithm from ESC and ERS 2022, we see the high-risk patient after risk 3 strata model, and down on the left, on the right side, we see the high-risk patient after looking in the risk 4 strata model. So this is the time that we change to this therapy. And in Vienna, we are using 2 different pumps, and the pumps are very small and simple to use, and they are very similar to insulin pump that even kids are using all over the world. And you cannot see, but I zoom it, so the dosage will be in microliter per hour. And this is the chrono subcutaneous pump, and the other one that is also in use in Austria is the Apex one. So actually this is a 3 steps of management. So we have to give time to the patient. Usually patients is in an inpatient department, and the right heart catheterization is done, and next day we go to the rounds and we say, yes, you have the pulmonary arterial hypertension, and we would, after talking to Professor Lung or Professor Skora-Sayer, we would like to recommend you the prostacyclin therapy. Patient needs time to accept this diagnosis, to accept the pump therapy. Because if they look in Google or whatever, if they talk to other patients, the first reaction of a patient is, I want to have a drug that needs to have a pump, give me a tablet or whatever. So time is a very important issue. And then after patient accepts the therapy, you have to train the patient before putting the pump in the body. So we have very experienced PH nurses, and they go to patient's bedside and train with the patient. So these are the equipment, look, we could do it like that or whatever. And even family members should be taking in part whenever you are training the patients. And also very, very important for the patient is that he or she knows that they have your support, either on-site, sorry, there's one E too much, on-site support or a remote support. And then together you can find the best solution. What is the best for the patient? That means refilling at home in patient's environment, or first days staying in the hospital and getting used to the pump, to the refill, to the numbers, to everything. So you have to discuss that with the patient. And actually, there is another 3-step of pump injection. You have the line. You prepare everything in a sterile setting, and then after the disinfection, you inject the needle and then fix the needle. And at the moment, we have 4 different treprostinil dosages: 1 milligram, 2.5, 5 milligram, and 10 milligram. And the management is, as we already have heard from Professor Skorosayer, very, very important. We have to prepare the patient that the pain will come. So within the first 5 days, this is very painful and it gets red. It can cause swelling. It can be really uncomfortable for the patient, and patients should know about these side effects in the first 5 to 7 days. And also, in some patients, they develop exanthema, or after taking the pump, they have like difficulties with her skin. So we have some managing, some recommendation. The pain resolves after 5 to 7 days. And this is really after each new injection. That means if the patient is like used to this therapy in the past 12 months and you have to change the injection sites, so the patient will have again the 5 days or 3 days of pain at the new injection sites. And please do not change within these 5 to 7 days. Just the patient should be patient and tolerate a little bit of pain, and it will become less and less. But if it is not tolerable for the patients, you can change the side from left to right or another part of body. And also very important, the pain medication can help with pain relief in the short term. You can use ibuprofen or other drugs that take away the pain from the patient. And you can also use some topical therapy as a steroid cream or anesthetic patch, and patients should have has the opportunity to contact the PH nurse and ask and get advice what to do if something is, I don't know, happens. For example, if the needle comes out or if there is a disconnection. So all patients have to have the card with the number of PH nurses. And I want to show you my favorite paper, and this is a very old one, 2006, and it says long-term outcome in pulmonary arterial hypertension patients treated with subcutaneous treprostinil. And they looked over 860 patients, and 199 patients discontinued due to adverse event. And in this paper, all adverse events that ever can occur are mentioned. So you see that the most frequently adverse events are side pain, side reaction, bruising, infection. And we also know from patients they complain about headache, diarrhea, nausea. But we have Also dizziness, anorexia, vomiting, all the side effects that we should be aware of as we recommend the patient this therapy are mentioned in this paper. Also very nice, there are writing about delivery system complication, so that the pump can be out of order, or the infusion set complications can occur, although in very low numbers. But even we have to know all these adverse events. And also in under 1%, very low numbers, they also mentioned programming error, many old people after the training, after they feel safe with working by themselves independently, they might make errors or whatever. They don't see the numbers or whatever. And this can also be we should be aware of. And also this accidental bolus, because after changing the tube, it can occur to give an accidental bolus to the patient. But the author said that in conclusion, no unexpected adverse event were observed in these patients. So the next topic I would like to mention is the dose effectiveness. And we know that we have 4 different dosages. And here I want to talk about the work from Vienna, from Roella Sadushi, published in Lancet, and Professor Skorosayer was talking about this paper. And here we see that patients with a high dose and low dose, there is a significant difference. So the 6-minute walk distance was significantly better in those patients. And also we can say, authors say that the long-term subcutaneous treprostinil is safe, and it is valuable treatment option for the severe non-operative and CTEPH. And yes, dosage matters. And the next issue that I want to talk is the different routes of administration. Also, this picture we have seen from Professor Skorosayer, and we know that there are different routes we can administer the therapy. And the next one that I would like to mention here is the IV treprostinil pump. We have a few patients in Austria, and they come every 3 to 4 weeks to refill, and they say patients are very happy to have these options, and they say this is a better quality of life, better than the subcutaneous therapy method. And here we have a paper from Aaron Waxman group from Boston, and they looked at 64 patients, and they were looking at the safety of this pump, and they recommend this pump too. So they have looked at they have had few complications, and the complication was pneumothorax was one of the complications, or infections, or the episode of atrial fibrillation. I don't know if this atrial fibrillation is really related to the pump, but implantation, but even they are reporting this complication. And post-implantation, they are reporting about the catheter dislocation in 2 patients. And these are, at the moment, we have in Vienna 3 patients on these pumps, and they are tolerating this pump very, very well. And so this is in a surgery setting, the pump should be implanted, and this is inside the body, and the refill should we use a very thin needle to refill the pump. And this is also tolerating from the patient. They do not even feel the pain of injection. And these are our pictures from our center. So at the beginning, if we have, for example, a little bit adipose patients, so we mark the route that we can easily inject or insert the pump. And then we can start refill the pump. Yes, and take-home message is we really have to work together, patient, physician, and nurse, PH nurse, to make a decision. And after the decision is made, we have to give the patient our maximum of support, so that we will be here for the pain management. They can ask us if something happened, discontinuation or whatever, so patient has to be safe with this therapy. This is my last slide, and I want to say thank you, and I will be happy to hear your questions.
Can you hear me, Rosa? Yeah.
Yes.
Okay, so we're going to have a short discussion because also Nika doesn't have much time, so she won't be until the end of this session. So one question, like a practical question for me is, do you have any experience when switching from low dose, not low dose of low dosage of treprostinil, but from this infusion, when you go to the 10 milligrams per milliliter, the concentration of the drug, do you think that there's a higher chance of having a local reaction, or is it more severe? We have had recently a couple of patients that went to 10 milligrams per milliliter, sorry, and they had more local reactions to subcutaneous treprostinil.
It is a question for me?
I think for both of you, actually.
Okay, so when you mean going from 5 milligram per deciliter to 10?
Yeah, just staying at the same, I mean, up titrating the concentration, but from going from concentration 5 to 10, yeah, of the drug.
Well, some of the patients claimed about infusion site pain, that's true, but I wouldn't say it's a regular, it's not an increase in dose. Only if you increase the dose, probably you can count with some more infusion site pain. Usually, I would say in 20% of patients showed some discomfort by changing to 10 milligram. But I wouldn't say it's not. I would say it's not in all patients, because it's the same dose.
Exactly, it's the same dose, but the concentration is different.
Yeah, but still, I wouldn't understand why would it hurt more.
It might be coincidental, I don't know, but
maybe
these were...
yeah, but some of them really claimed about it. You're definitely right, but I wouldn't say it's not in all patients. I would say maybe 20% of them.
Do you then have an instance when you went from 10 to 5 after that happened, or you just sticked with the 10 concentration and?
No,
in
no,
one
we
way?
never change. So we stick with the highest concentration.
Okay.
I never go down. Because yeah, I think we underdose our patients. You know, yeah, I think that's the most important problem by using a subcutaneous treprostinil, because you always have to discuss with patients because they're afraid of every single injection site change, every single increase. So when we actually had a PH meeting just last week, Professor Matevž shared with us the data about patients on triple therapy going with IV epoprostenol for 50 nanograms and then turning to normal hemodynamics. So I think that actually 50 nanogram epoprostenol would be 100 nanogram of treprostinil. But how many patients do we have in the first year on such high dose? I don't think so that we have so many, and that's a problem, you know. I think underdosing is a problem. Maybe we stabilize our patient, but they can never get normal hemodynamics.
Yeah, thank you. And also one question for Rosa. Do you have an experience for allergy to this infusion site, the glue? Because we also had some patients being stable for quite a while in some cases. And then I think it was the infusion set, different set. And then they get sort of a local reaction just around the infusion site, like an allergic to glue or something. I'm not sure.
Yes. So I personally do not have experience with the allergic reaction. But I think this would be like with a steroid therapy or with a local therapy would be manageable for the patient.
Do you often use antibiotics when it comes to infection of the site, or do you just switch the site and then let it be? I mean,
well, it depends, of course. If they have a high CRP or other signs of infection, I would treat with antibiotics. But if they do not, then I would just treat locally and change the site.
Thanks.
Concerning it's subcutaneous.
Yeah, subcutaneous.
And Rosa, I would like to ask you what, when, or both, decided for the implantable pump. How do you assess the patient according to prognosis and to stability? How stable they should be to decide to do this switch? How long already on the sub-Q, and how stable according to prognosis? I know.
So I mean, the compliance is very important.
Yeah,
you know,
of
so
course,
if the patient is really compliant, so
yeah.
you can think about the changing to IV, because IV, they should not miss the time of refill. You know, if they miss the time, so they will go without the therapy, and they go very fast, go to the right ventricular failure, you know. So the compliance is important. And then there are many patients, they still are reporting about pain. We cannot say if they have pain, maybe because they read that there are other options and they want to have this option. And in this case, we discuss together, and if the patient is eligible for the IV pump, we will do it. But I don't know, Nika, do you want to say?
Yes, I can add something. Well, I must admit that we routinely do not switch patients from subcutaneous to IV. So due to lack of this experience, I just cannot say when we switch, because we don't switch. Actually, if they manage the pain somehow, I just leave them on subcutaneous, because these patients have to be really stable. They have to have achieve the doses which are significant, which significantly improve their hemodynamics, of course, and exercise capacity and pro-BNP. So they have to be, in my opinion, they have to be really stable on high doses to switch them to IV. So we try to manage infusion site reaction and not to put them on IV pump. So due to only 3 patients, I don't know how many we had, maybe 5 or 6 patients on IV pump, and we have experienced some complications also undergoing surgery, complication, like pumps going out from the belly, etc. Maybe Rosa, you can also report something about it. So so it is, of course, if it works smooth and optimally, then it is a good option. But still, we have much more questions than answers concerning
very rarely
IV implantable
the decision
pumps.
comes very rarely. Okay.
Yes, for because you mentioned, Nika, the complications. So we have once the very thin or low body weight woman, and the pump side, the skin opened and you could see the pump, you know, but she did not have any CRP or sign of infection. She just came and said, oh my God, the pump, I can't see my pump. And we immediately admit her to the inpatient department and resurgery, and we changed the site of the IV implantable pump. So this can happen if patient's body condition is not suitable, you know.
Mm-hmm. Okay. Yes, and we had also one occluded catheter, and so you are, of course, in the position to put a stable patient in an unstable situation. So you should have a very good surgeon, you should have a very good team. So it's even more complicated than subacute treprostinil.
More decision contra. Yeah.
May I ask one question? Yeah. Sorry, Barbara.
I just would like to welcome all other speakers, Professor Matjašević, Professor Ristic, Primari Hečimović, welcome. We make this discussion.
We are happy to discuss it with you.
In the middle, according to prostate cyclins, and we decided also to
we don't have pumps
have,
in Serbia.
If you have some,
you don't have any?
No, unfortunately, we are preparing for the first patient. Maybe could Arsen tell something. But I have a question for these implantable pumps. Is it complicated to refill that pumps? It seems to me it's quite complicated to find, you know, the right point where you should put the needle. And what's your opinion? Is it complicated or not?
So it's a very good question. So it is not very complicated when patient's body is in a good shape. You know, we have had adipose patients, so that subcutaneous adipose issue is thick, and then you have difficulties to find the silicone to put. And then at the beginning, we have one patient with this problem. We went to the cath lab and we did the X-ray, and then under the X-ray we insert the pump, you know. But it was at the beginning, and now she lost weight, and now everything is fine. But usually if the patient is in a normal weight condition, it is not a problem. So it's only learning by doing. But we also at the beginning used sometime ultrasound, you know, to see and it's very usable to have the pump as a demonstrative tool next to you, so that you can see where the silicone can be, you know, and then it's possible to do.
Yeah,
I think it
it's
depends on
complicated.
location of the pump, of course. If it's very superficial, it's very easy to find a silicone membrane, and usually Rosa does it, but in a couple of times I did it too. Maybe there were special patients for me, but it did work very well.
Okay. So,
Thanks.
so thank you. Any question more? Huh? Otherwise, thank you, Nika, Rosa. Great pleasure for your presentation, nice presentations to stress the importance of prostacyclin still in this era of new drugs which are coming. And thank you, both of you also, especially Nika, to you for all cooperation during these years. Yeah.
Thank you, and we look forward for future projects and future patients and collaboration.
Thank you. Yeah. And now because we are still here, Professor Ristic, if you agree, because we are now in the middle of the drug therapy, you will wrap up at the end with the obstacles due to this, and we will continue first with Anna. With the Primari Hecimovic from University Clinic in Zagreb, Croatia. We also have very nice contacts with you and Professor Professor Samardzija, and I would like to invite you to have the lecture about combined therapy, oral therapy, which is preferred by patients and might be also in good responders long-term effective. Anna, please.
Hello to everyone. Thank you very much, Barbara. Thank you for your kind invitation to share with you some our experience with long-term benefit of oral combined PAH therapy. Greetings from my University Hospital Center and also from Professor Samardzija. When we look for the guidelines and seek for the answers how to treat our patients, then we clearly see that patients who are in a functional class 2 or 3 are candidates for oral treatment. In the last 2 guidelines, we also have to take care of risk assessment of our patients to see what is the 1-year mortality risk in our patients, and if they are in low or intermediate risk, we can give them oral therapy. In 2015, there was recommendation that we can start with monotherapy, but today there is a clear recommendation that we should start combining treatment in patients who are in low or intermediate risk. What we know from the clinical trials when we talk about oral therapy is the data that we get are for a shorter period of time. But when we start the treatment, we actually don't know how will our patients respond and for how long will this good response, if we have it, going on. So the real long-term data we actually get from the real-life trials or our clinical experience. Today I will show you our 2 patients. First patient is now 48 years old, and she was diagnosed with idiopathic PAH when she was only 7 years old. That was a long time ago, at the time where none of the selective vasodilators that we have today, they didn't have when they started the treatment. And she was treated with verapamil. She had good response and she was stable at the moment when she was referred to our clinic. more than 20 years after the treatment was started. That was in 2006. At that time, the right heart catheterization was repeated, and we had in front of us patient who still has a positive test, but at that time, I don't know why was this decision made. Prostaglandin inhalation therapy was started to this patient, and during the next year, she was stable on verapamil and iloprost inhalations. We also knew that she has dilated pulmonary trunk, and in 2012, she had some new symptoms. She had hoarseness, and we went to check what is going on with her pulmonary trunk. It was dilated to 5.7 centimeters, but there is no signs of pulmonary artery dissection. In the next 5 years, she continued the treatment. She only had mild symptoms, but at the beginning of 2017, something started to happen with her. She had a little bit more dyspnea than before. Her walking distance was significantly shorter than before, and the value of NT-proBNP rise. So we decided to change our treatment approach and to introduce another drug in her treatment, and we started the treatment with macitentan. Values of NT-proBNP decrease, and in another years she was also stable. We also checked her by CT angiography to see the pulmonary trunk dimension, and after 7 years it was only 3 millimeters larger. In June 2021, we noticed again that something is going on with her, that her walking distance again becomes shorter, and we noticed the elevation of NT-proBNP values. According to echo, it was pretty much, everything was pretty much the same, but at this point we decided to replace iloprost with selexipag, another drug from prostacyclin group of drugs. We had some challenges during starting the treatment because it was COVID-19 still very active, and we decided to do this up titration of the drug in her home, and we contact her by phone or email, and unfortunately she had some side effects, and we couldn't do up titration as we should do it by the how it is done when the drug is prescribed. We do the slow step up of the dose, and we stopped the dose and at 800 micrograms twice daily. That was the dose she tolerated very well. And she also tell us that she's feeling better, that her dyspnea is less expressed than before. She has less daily oscillation of her symptoms, and something that is also very important for our patients, especially for those who are on long-term treatment. She had better quality of life because now she had to take this drug only twice daily, and before she had 6 inhalation per day. During the next follow-up after 1 year, she was still stable. Anti-pro-BNP values went down, and her last checkup was about 2 months ago, and her walking distance was still very good, and it is longer than it was before. Our second patient is a little bit older. She's now 61 years old, also female patient. She was diagnosed in 2013. Before that, she had symptoms about 1 year before performing the right heart catheterization and establishing the diagnosis of idiopathic PAH. When she came to our clinic, she had signs according to echo and also right heart catheterization of right heart failure. Her walking distance was only 280 meters with significant desaturation during the test. And at that point of time, we decided to treat her with monotherapy. We gave her sildenafil. From nowadays point of view, we clearly will have a different approach and a different strategy of treatment, but at that point of time, she get monotherapy. 6 months later, 4 months later, she was a little bit better. Her walking distance was a little bit longer, but there was no significant change in her echo parameters. In April 2014, about 1 year later, we had another worsening of her symptoms. Her walking distance was worsened. Her echo also didn't look very well, and we decided to give her a second drug. Macitentan was started at that point. During the next 2 years, she was pretty much stable. She felt better. Her dyspnea was significantly less exposed than before. Her walking distance was significantly longer, and we also had this very good improvement of her right heart with no signs of right heart failure. But in 2019, we had another clinical worsening with progression of dyspnea, elevation of anti-pro-BNP levels, another worsening on echo, and now we decided to treat her with treprostinil. But this didn't get very well because she had severe local side effects. We tried to motivate her to stay on this treatment, but she refused that, and we have to stop the treatment. Since we only have treprostinil and iloprost in our center at that time, then we decided to try with inhaled prostacyclin instead of treprostinil. With this treatment, she was stable, but she never quite improved, and we didn't get improvement like we had after we introduced the second drug to her treatment. And in July 2021, we still had high levels of NT-proBNP. Her right atrial was quite large, and now we had an opportunity to introduce another drug to her treatment, and that was Selexipag. After we gave her this third drug, we get another significant improvement in her condition. The level of NT-proBNP was decreased, and her last check-up in our clinic was about a month ago. She is now in a very satisfactory clinical condition. Her walking distance is longer than ever before, and her echo parameters are stable. When we, what we see from these two cases and from our clinical practice, good clinical response and long-term good clinical response we usually have in younger patients. Some data from published papers also show this. This model-based survival curves also shows that younger patients, we have here example of 40-year-old women and 70-year-old women, and younger patients have a better treatment response. Based on our experience, we can say that long-term oral treatment it is reality, and patients can improve and stay in stable condition only by oral treatment. Thank you for your attention.
Anna, thank you for your really nice presentation where we see that that this oral has a future, and that also this new oral Selexipag is effective and might be good options in patients like your, and we know when to use it. The discussion will be at the end, and now I would like to ask Professor Matevž to have another presentation, and at the end this he will present this group of patients with better prognosis who are vasoreactive and responders on calcium antagonists, but long term it might happen that they deteriorate, and so he will explain us what to do then. And please, we have to wait a little bit technically, and we start with his presentation then.
Hello, everyone. May I share my presentation? Can you see my presentation?
Yes, we can see your presentation.
Hello, everyone. Can somebody tell something from organizers?
We can hear you and see you.
I can see your presentation.
You see my presentation? I
Yes, it's everything clear. I can see it.
We see and hear you loud and clearly.
Okay, thank you very much. Thank you, Barbara, and all of you for inviting me to your symposium. I'm honored, and I'm sending so many greetings from Novi Sad, from a little bit rainy Novi Sad right now. And I will try to fit in 10 minutes presentation, as I understood very well. Barbara told me that you should be the precise in 10 minutes presentation, and I will be on time, I hope. This is a little bit similar subject comparing with the previous one. I will present one case using a calcium channel blockers, and I would like to share with you our concern or our doubts we have in this case, and you will see it. I'm talking about 53-year-old female patient with Hashimoto thyroiditis, and she was diagnosed in 1999 in Institute for Cardiovascular Diseases of Vojvodina, which is part of our building, but I'm coming from Institute for Pulmonary Diseases of Vojvodina, which is in the same building, but we are in different parts of the building. And at that time, as you can see on the picture down, they performed the right catheterization, and they have got the mean PAP 35 and wedge pressure around 10. At that time, they started with treatment with the calcium channel blocker with diltiazem 90 milligrams twice daily, and the diagnosis, according to the patient, she wanted to go somewhere else to have a second opinion. She went to AKH Vienna, and at that time they confirmed the diagnosis of IPEC and continued therapy with calcium channel blockers at that time. During follow-up, patient was at functional class 1 with walking distance test above 440 meters, NT-proBNP in reference range. After approximately 18 years, at September of 2018, she remains in functional class 1 with 6-minute walking distance above 440, NT-proBNP, which was in normal range. Echo performed at that time in 2018 showed that the right ventricle was slightly dilated with normal typeset 22 millimeters and right ventricular systolic pressure around 44 millimeter of mercury. 4 years later, in April 2022, she developed progression of symptoms, of course, and declining with the physical exertion, and she was at that moment in functional class 2. Previous, she was in functional class 1. She developed peripheral edema and single event of syncope. 6-minute walking distance test performed in April 2022 was astonishingly for 425 meters. NT-proBNP was elevated and quite about 2,000 picograms per milliliter. Echo showed ERA area, which was a little bit higher than normal ranges, 24 centimeters square. TAPSE normal, 24 millimeters of mercury, and RV-LV ratio 1.2. Right ventricular systolic pressure measured between 55 and 60 millimeters of mercury with TR3 plus, without pericardial effusion. She, by herself, stopped using anticoagulation 2 years ago, exactly in 2020. We performed the CTPA, and we saw that she had a right-sided pleural effusion and pulmonary thromboembolism with segmental branches for the middle lobe and basal bouquet, and minor defects in the segmental branches on the left side. We performed also right heart catheterization with vasoreactivity test, but at that time test was negative. Parameters, hemodynamic parameters were the mean RAP was 12 millimeters mercury, mean PAP 55, wedge pressure 10, cardiac index very low, 1.8, PVR 15 Wood units, quite high, and mixed venous saturation 65. Thyroid hormones in therapeutic range. Creatinine, liver enzymes, and complete blood count are within the reference range. PFT, pulmonary function test, also was in reference range. That was challenging for us, and at that moment, according to the negative vasoreactivity test, we stopped calcium channel blockers and started with the PDE5 inhibitor, sildenafil, 20 milligrams, three per day. We started combination therapy with ERA, bosentan, with a half dose, 62.5 milligrams BID. Because she developed pulmonary thromboembolism, we started with DOAC, rivaroxaban, and diuretics, continuous levothyroxine, and pantoprazole. Something's going wrong. I cannot move my slides. That's it. Yeah. After discharge and initiation of specific pH therapy, she developed clinical worsening. We connected hypotension, flushing with sildenafil, itching, pain, edema, and syncope with bosentan, and at that moment she was in functional class 3, which was much worse than previous. 6-minute walking test was at a very low level, 110 meters, previous was 425 meters. NT-proBNP elevated also and reached the level of 4,000 at that moment. CBC, we noticed by cytopenia with low white blood count and platelets with normal hemoglobin. Creatinine, liver enzymes, CRP are within the reference range, and virological analyses were negative. ECG, sinus rhythm, heart rate 90 per minute, dextrogram without signs of ischemia. This was the big challenge for us, and as you can see, these 6 components of our doubts, I put it on the slide. And what was the first question? The first question was, should we return the calcium channel blocker or continue sildenafil in spite of flashes and all side effects? Continue bosentan by cytopenia, diuretics, low weight molecular heparin, or continue rivaroxaban. Of course, we look at the new guidelines from 2022, and we have the noticed this one recommendation in a patient with a positive vasoreactivity test but insufficient long-term response to calcium channel blockers who require additional pH therapy. Continuation of calcium channels blocker therapy should be considered, and we decided to continue with the calcium channel blockers. Anticoagulation is not generally recommended in patients with PH, but may be considered on an individual basis, and we decided to continue rivaroxaban because she had pulmonary thromboembolism. And her therapy at that time was we returned the calcium channel blockers, continuous sildenafil without bosentan. We tried to advise the patient to accept maybe a new kind of drug, maybe macitentan. She refused. She didn't want to continue with the new drugs. We decided to give the diuretics, low molecular heparin after normalization of platelet count, and continue rivaroxaban. 1 month after discharge, she went for the control, and she could tolerate physical exertion better. Now she is in a functional class 1. She improved very well. NT-proBNP in a normal range, 6-minute walking distance test, 400 and 5. Previous was 110, and echo parameters improved. And there is a magic sentence from the guideline that we catch it, that in some cases, in combinations of calcium channel blockers with approved pH drugs is required because of clinical deterioration with calcium channel blocker withdrawal attempts. And we raised a few questions, maybe for discussion. Continuation of calcium channel therapy plus pH therapy. What's your opinion? Or maybe false negative vasoreactive study we performed in our cath lab, and individual decision making for anticoagulation. And this is all from my side. If you have a question, I would like to answer. Thanks.
Professor Matevž, thank you very much. If you agree, we will have discussion at the end, as we planned, or you have time to be with us until the end?
I can't hear you well, but never mind. I understood that questions will be at the end of the session, yeah? Am I right?
We will open this question because they are really very relevant. And first, just to hear the obstacles in teaching to the new guidelines. So I would like to invite Professor Ristic from to have the presentation. Obstacles in implementation of the new guidelines on pulmonary hypertension in the routine clinical practice, what is also part of your questions, I think. So we have to just wait that he will connect again. Kaj ga ni? Ni? Ej, a na moj mobitel na WhatsApp povprašaš, poklič ga tam. N je, N. Ti vprašaš.
Denis? Okay. But in the case he's not here, perhaps I can have the presentation, and then at the end, actually it was past at the end the obstacles, and then we will discuss the obstacles. So I just would like to wrap a little bit those novelties of this year 2023. Just to wrap up what was already said during the meeting, the symposium. So as we are slowly coming to the end of the symposium, and I will just, with these novelties, wrap a little bit what was already said today. So, kako je bilo pri doktor Topliško? So, as we see, that this year is really special because it is, as Professor Lang already said, 50 years since the first World Health Organization Symposium in Geneva, where the disease was identified after this epidemic of pulmonary hypertension in young women who take aminorexigens to slim on easy way. And then after 25 years ago, the first clinical classification was then set, according to which we have a tool to better identify the groups and to identify how to treat them. And 20 years back from now, we have all three options of specific drugs which act on the endothelial of pulmonary vessels. And since then, as you see through the symposium, it is really important to early detect, to make a correct diagnosis and to make a correct decision for the treatment. And with this, we can really improve the prognosis of otherwise very severe disease. And after this last symposium in Nice, there are important implementation of new guidelines for PH, which are to correctly diagnose and to correctly then decide to treat. A new definition come with lower, now we will all remember the definition is lower, mean PAP 20 millimeters of mercury, and in addition PVR over 2. And new approaches to treatment. So in classical form of PH, very aggressive, early, combined, with versus gradual therapy in those who has some kind of non-classical or combined, as we talk, combined with cardiac diseases, with pulmonary diseases. And there are still open questions how to detect correctly those patients. And we can expect next year new guidelines, as Professor Irene or Professor Lang already told us, and a new approach to the treatment. So treat early on these three pathways of endothelial dysfunction. So in the pathway of endothelin, so we block endothelin pathway, or accelerate the pathway of nitric oxide, or the pathway of prostacyclins, which are still the most effective drug, but with very difficult approach. are IV or sub-Q. So in this situation, we still have the question, what about peroral drugs in this pathway of prostacyclins? And the other one, because there are still patients who are non-responders, to find new pathways with new drugs, not only on the correction of endothelial dysfunction. For the first question, there is answer already in the new drug Selexipac. Primari Hechimovic already show us 2 nice cases, which responds very good on Selexipac. And this is used in patients with low intermediate risk, according to the new classification, but also we can try with these drugs in patients who are not keen to have these difficult approaches, and then perhaps in them, if the drug isn't effective, they decided easily to then accept the pumps, or if it's effective, then we are all happy. And in this year, also Selexipac is on the positive list in our country, so we would like to thank the cooperation with medical pharmacy, where this is a win-win situation, where the patients benefit the most. And we can see that it might be really effective. Selexipac, Uptravi is effective. It might reduce risk for 37%. In triple combination with ERA and PDE5 in comparison to only double therapy. And it might be effective even more in those patients with more severe disease, in connective tissue disease, and also in congenital heart diseases. So we are really happy that we have this drug. And of course, in patients who are non-responders, we will have another possibility. This is the first drug which is not on, which acts not on the endothelial dysfunction, but through inhibition of activins. And there are still many open questions, as Professor Lung already told us, but still we expect a beneficial effect in those patients who are not responder to endothelial, to those drugs from 3 groups of which improve endothelial dysfunction. And the results of studies will come when it will be approved. And in Slovenia, we already have approved that as soon as the EMA confirm the drug, we will have compassionate use of this drug. And we are looking forward for this new drug. So also thank you to another pharmaceutical company. Again, one win-win situation. And so in the summary of this practical, these are really, there are many novelties, but these are really practical, so that we have guidelines, we have new definition, so MPMP20 and PVR over 2 and wedge pressure below 15. We have new phenotypes. Here we can expect some new, because still open questions. Is this combined or out of proportion pulmonary hypertension? How to treat this? Okay, sorry. How to treat these 2 groups? Classical, of course, very aggressively. And so the new, more effective approach to treating pH with specific drugs, with combination in which the prostacyclin still remain the most effective drug. And in this pathway, the new Selexipac, and we can expect for non-responders several new pathways, and sotatercept is the first one which will be clinically applicable. With this, I would like to thank, in the name of our center, and again, here are our emails, and help you, and thank you all. Professor Ristic is here. Okay, we are so happy. I think that we have to conclude without you. So I will conclude this last slide.
If we have time, I can do it in 5 minutes, whatever you prefer.
I will this slide put for the end, yeah.
Mm-hmm.
Now, Professor Ristic, what are then obstacles in this?
There are so many, I can talk about this several days. So, but it's really a pleasure and an honor to be together with you, and I really hope that we will have soon another opportunity to meet in person. And I can just share my presentation, and it will really last less than 10 minutes. Okay, sharing my screen. PowerPoint. Very good. Do you see my screen?
We see the stream and we hear you.
Very good. Okay. It just starts from the beginning. Okay. So the new guidelines on pulmonary hypertension have really changed our clinical practice, but some of the obstacles are still present in the real clinical events all around the world, especially about the availability of the diagnostic tools and about the availability of medications. And what certainly also introduced the new line of obstacles is the new definition. And we were very glad that exercised pH is now also well defined, and that we have the hemodynamic criteria. Having in mind that, however, this methodology and labs for the exercise testing in parallel with invasive hemodynamics are not routinely available all around the world. Another obstacle in implementation of the guidelines is also vasoreactivity testing, in which we also have the introduction of medications and inhaled, or actually the list was changed. Inhaled nitric oxide was the #1 medication all the time. However, the devices to do this type of testing and or inhaled iloprost or IV epoprostenol, they are not also widely available. So the vasoreactivity can be a limitation for some of the countries and for the implementations of the guidelines, although it is a long-term standard, and the recent guidelines have only changed the list of the agents. Furthermore, the grading of the evidence and the combination of, or actually application of PAH medications in HFpEF patients is also one obstacle, since with the downgrading of hemodynamic criteria in the guidelines and the introduction of a lower pulmonary vasoreactivity as a criteria for the diagnosis, inevitably some of the HFpEF patients are falsely diagnosed as PAH. Therefore, one of the obstacles should be also to carefully differentiate HFpEF from PAH and other subtypes of pulmonary hypertension. Another important issue is heritable pulmonary hypertension, and heritable forms are described in the new guidelines with much more details in comparison to the previous one. However, the availability of genetic testing is also an obstacle, and we are very happy that in the last 2 years we have the option to do the genetic testing for patients, and that this is reimbursed. In the past, this was very limited because of the lack of reimbursement, and this lack of reimbursement for genetic testing is also one of the obstacles worldwide. Another important limitation or obstacle can be wide availability of biomarkers, and biomarkers as BNP and NT-proBNP are routinely available in the larger hospitals, in tertiary centers, but not routinely available in primary care in many countries, and this is certainly one of the obstacles, as it is the fast track option in the guidelines due to the limited capacities of pulmonary hypertension centers. So we are trying to keep with the spirit of the guidelines and to enable the fast track, but this is usually also limited by the capacities regarding the availability of equipment and people and the capacities of PH centers. Furthermore, cardiopulmonary exercise testing that is strongly reinforced with these guidelines, and is certainly bringing a benefit in the initial diagnosis and in follow-up of PH patients and pulmonary hypertension in general, is also rather complex methodology requiring rather expensive equipment, and also not widely available in all countries and all centers, and there are PH centers with limited access to cardiopulmonary exercise testing, which is certainly one of the obstacles. When we have the diagnosis and we have the indication for treatment in high-risk patients, it is usually not so easy to start with expensive medications in the first line, especially intravenous subcutaneous treprostinil or prostanoids in general are not fastly or promptly available in our setup. So one of the obstacles to follow the guidelines could be availability of medications and oral medications and oral combinations, especially of the generic drugs, is now improving, and it's much better than it used to be in the past, but this is still the limitation. Also for the new recommendation regarding the preferred combined initial therapy like ambrisentan and tadalafil can also be an issue because, for example, in our area, tadalafil is only available for erectile dysfunction, and ambrisentan is available with a delay of up to 6 months. So for the initial treatment, we still have to stick to sildenafil and bosentan, which is now not according to the guidelines. For macitentan, we also have to wait our patients have to wait for a couple of months. Very important decision-making point in the follow-up of PAH patients according to the guidelines is the follow-up visit, when we, in intermediate low and intermediate high risk, also need to switch to the more potent medications like riociguat or oral prostanoids, or to indicate intravenous prostanoid therapy, or to list the patients for lung transplantation. And the availability of lung transplantation in several areas of the world is still unfortunately limited, as it is in our country. So the Dept is coming. We had very encouraging results from the Pulsar trial. We also had excellent results from the Soteria trial, and this is not in the guidelines now. And in this excellent recent review from Mike Humbert and several other prominent experts, there will be still certainly need to modify the current treatment algorithm and to find a place for sotatercept and the most appropriate position in the future. And this might be also the first chance might be in the PH symposium and in the following documents, and we might expect an update of the guidelines according to or similar to this proposed treatment algorithm. So the same is true about the obstacles in CTPH, the availability of balloon angioplasty, the availability of prompt availability of riociguat, the prompt or availability of pulmonary endarterectomy or reimbursement for those procedures is also not universal in all the countries, and some of the patients are treated only symptomatically and could be better managed with either surgical or interventional approach. Therefore, in concluding the list of obstacles, still we are diagnosing patients too late. We still need to work on the better education of clinicians for proper differential diagnosis and to avoid treating HFpEF patients with PAH specific medications. The access to expert centers is not that prompt especially for the rapid transfers, availability of biomarkers, genetic testing, and of course availability of state-of-the-art equipment is lacking. There are issues and obstacles also in dedicated rehabilitations program and in know-how regarding how to perform and interpret right heart catheterization, which is still not at the appropriate level in quite a large number of centers. The same issues are true for dedicated intensive care units, which are not available in all PAH centers, and obstacles regarding the management of pregnancy, which significantly changed in the new guidelines, are certainly present, and the need for education on pregnant patients is certainly there. Therefore, for those patients and for the more appropriate action to overcome the obstacles, we need to further increase the public awareness. We need to improve the availability of contemporary medications and other management options, and we need to continue our cooperation in order to improve the quality of our national international registries and to join our forces in the further research for the new options in implementations of the guidelines and in implementation of the new treatment strategies. So thank you very much for your kind attention, and sorry for being late for my initial time for this presentation. I'm looking forward for if you would have some questions.
Can you hear me? Does it work?
Yeah, of course.
Okay. So we finished our session, and we're finishing with the discussion. Already, I think, Rosa, you raised a hand if you're still with us. You had a question probably for Professor Matevž regarding treatment with calcium channel blockers for patients with vasoreactive IPH. Are you still with us, Rosa?
I think she's not.
Okay, maybe she'll join us. We, from my experience, maybe from Barbara's experience, we saw a few patients on calcium channel blockers. Some are still quite stable for quite a long time, 10 years or maybe even more. But we don't tend to put them off calcium blockers because we are afraid of the rebound phenomenon. So usually when it comes to the progression of symptoms, to progression of disease, we tend to add additional specific therapy. Maybe Barbara, you can add. So we don't want to put them off calcium blockers, just to add additional therapies. All three, actually.
Which three?
I I mean, from all the three groups. So from group which is the NO pathway, the nitric oxide pathway, the prostacyclines are also from ERA pathway. So we just add the drug, of course, if the patient can tolerate it due to low blood pressure and all the side effects.
And this is in line with your good results when you give this patient calcium channel blockers back.
Yeah.
But another point which is really very important, you find pulmonary thromboembolisms in addition. In 1 hour patient, when progressed, we find severe OSAs, obstructive sleep apnea, and she has got then the CPAP mask.
That's the pulmonary disease. Let's don't confuse the cardiologist.
This point, I like this point in this patient.
I just joke.
Barbara, unfortunately, I will have to leave. Many thanks for this opportunity, and I'm looking forward to seeing all of you in the near time in person. Many thanks. Bye.
Okay, thank you. Bye.
Bye. Bye.
Okay.
Okay.
Thank you, Barbara, for everything. And okay.
Some questions more?
Maybe just one comment more. So the difficulty I see when I'm gaining some experience with pulmonary hypertension is that the subclasses can be overlapping, as Barbara said. So we can have a patient with systemic sclerosis, additionally having ischemic heart disease, so class 2, and also could have class 3 of pulmonary hypertension. So it's really hard to discriminate which is the leading cause. We usually use quite a lot of parameters when we decide how to treat. Of course, right heart cath, pulmonary vascular resistance, DLCO, how much of the interstitium is damaged. But yeah, it's not as simple as it is in the guidelines, where there are 5 classifications, 5 groups. Most of the patients have more than just one group of pulmonary hypertension, so it's really challenging to treat them.
Anna, thank you for your case reports, which were really very promising for the Selexipac. And one question, what are you planning for the future? So in the case of deterioration, you will start with parenteral then, prostacyclins.
Yes, that's the only solution that we have in these 2 cases.
Okay. And then to lung transplant list.
Yes.
Yeah. Okay. Thank you. Now,
can I ask one question, just for 1 minute? How is going lung transplant program in Croatia and Slovenia? After going back from the AKH Vienna to your origin cities?
Yeah, I would like to invite...
just a short answer.
Harlander, our chief. And
hi. Maybe I can reply to this. The program is working in Slovenia. We have between 10 and 15 patients every year, which is about to be expected from these indications. I can't talk about Croatia.
It's also going on in Croatia, yes.
So the referral for transplantation is possible in Croatia and Slovenia. That was brief, yeah?
Very good. Thank you very much. Yeah.
Matevž, there is a problem for PH patients because they don't get enough high blast score.
It's important that you have to refer the patients with pulmonary hypertension early enough because the scoring system for lung transplantation was not developed for vascular disease, which is PH. So the patients with PH will typically get low score because they have normal lung function, yeah? Which is a major parameter for mortality in lung diseases. So typically, a patient with PH will have a long waiting time. So don't count on these patients to be transplanted in 2 months, even if your right heart catheter is awful. It will not determine the priority. Then you have the patient on ECMO, well then it's urgent, but it's much more complicated. Yeah? I think when you see that the patient with a PH is starting to deteriorate or the response to triple therapy is not optimal, that should be listed, the patient. Yeah? Although there is clearly a lot of advance in this field now that patients have better prognosis and the time to some major event is much longer than it used to be maybe 10, 15 years ago. But this is always a difficult question. Selecting the proper time for listing of the patient is an art. It's yeah. You can open the guidelines, but at the end is an art. Yeah.
Will you then close the?
Yeah. I have one more, a few words before we close. So I want to say thank you to Barbara, because I must say that you are a pioneer of pulmonary hypertension in Slovenia. You've been working with these patients for decades now, and since we had no drugs to now, where we actually, I think, we have a modern management of these patients, and I think they're grateful to you, and I just want to say thanks, and I hope you'll stay with us and learn as much as possible until you stay.
And I would like to thank you both. I'm so happy that you are really so dedicated to pulmonary hypertension, and really thank you once again to Dr. Goryuk. And I would like to mention there were invited Professor Shabovic. He was actually the first one, and then after him I started with this. Yeah.
Just as I did.
Oh, voilà. Thank you. And to our chief that support this path. Yeah. This is the most important thing because, yeah.
Okay.
Yeah.
I don't know about that, but I was told I have to close this meeting today. So I would like to thank to all the presenters today for a nice overview of the modern management of pulmonary hypertension, both from diagnostic point of view to therapeutic point of view. I see that there has been significant progress in the last 15 years. I think we started with Revazio and Bosentan, if I remember correctly. And now there are much more drugs available, and the prognosis of the patient is better. I think I only need one microphone. But I would like to especially thank to our teachers that have also attended today's meeting, Professor Galie, Professor Lung, also Dr. Goryuk, who is sitting here with us in the room. Those were the cornerstones of the program in our hospital today, which I think offers to patients here all that medicine can offer right now, at least outside of the clinical studies. So with this, I think we can close this meeting today. Yeah?